hill sacks. Hill sacks with more than 30% of femoral articular surface contribute to recurrent anterior instability even with capsular repair. So that requires additional hill sacks repair procedure like limb plissures or the bone grafting. So then comes the glenoid bone loss, bone lesions of anterior and posterior glenoid rim. 15% of recurrent anterior dislocation have bony banquet. More than 25% glenoid surface warrants bony procedure. Defects smaller than 20%, soft tissue procedures will be sufficient. So others, you can see the repetitive injury like pitchers, swimmers, throwers, volleyball players, where they have microtrauma, repetitive trauma, it may cause anterior instability or a period of time. Intrinsic capsular laxity is another factor, and inherited disorders like Ehlers-Danlos syndrome, all these will have repetitive trauma on the shoulder joint because of capsular laxities. So in this table, you can see that the potential structures involved in shoulder instability in anterior dislocation, SGHL, MGHL, anterior IGHL, which has a more importance of anterior IGHL, anterior capsule and coracohumeral ligament, superior anterior labrum, long head of biceps and subscap, and posterior, again, SGHL and posterior IGHL, and posterior capsule and coracohumeral ligament. In multidirectional dysfunction of dynamic stabilizers, joint capsule in 2 or more directions, inferior capsule is usually primarily affected in multidirectional dislocations. All structures involved in anterior or posterior instability can also be affected in multidirectional. So this is a very basic pathoanatomy of the shoulder instability, where you can see all the structures and identify the lesions, and accordingly the treatment protocol will be programmed. So thank you very much for a kind attention.
We'll have questions later. Next, Dr. Virendra Mudnar on clinical evaluation of instability.
Dr. Virendra Mudnar is a consultant orthopedic and joint replacement surgeon, Apollo Spectra, Kondapur, Hyderabad. Has multiple fellowships in shoulder arthroscopy, and he's got many academic achievements to his credit. So we'll be discussing on the clinical evaluation of shoulder instability.
Very good morning. I am Dr. Virendra Mudnar. I am practicing in Apollo Spectra Hospitals, Kondapur, Hyderabad. I basically belong to Karnataka. I have been practicing in Hyderabad for last 14 years. In today's session, I'd be talking about the clinical evaluation of shoulder instability. So whenever we examine a shoulder patient, although there are a lot of clinical conditions to be examined, we should always bear in mind that a patient will not come with an isolated individual condition. There could be an associated condition as well. So we're supposed to look for the associated conditions. In today's session, we will just discuss about the clinical evaluation of shoulder instability. So the types of shoulder instability has been discussed in the previous session. I will skip this. You will basically, we are supposed to differentiate whether it is an acute trauma or a traumatic one or an atraumatic one. In atraumatic one, we are supposed to assess the ligament laxity, specifically in patients who have got generalized ligament laxity. Depending on the direction of the dislocations, it could be anterior, posterior, or multidirectional. When we examine a patient, it is very important to elicit and talk to the patient regarding the history. Depending on the age of the patient, the sex, occupation, associated comorbid conditions, we are supposed to come to a clinical diagnosis. The onset of symptoms, the history of previous episodes, previous surgeries are very important. We'll have to discuss with this when the patient comes into a clinic. We should also identify if there is any associated rest pain. Rest pain usually indicates there is an associated arthritic changes or infection. You got to, sometimes the patient would definitely tell that he has got a definite functional limitation, that he's not able to comb his hair, he's not able to reach the back side of his pocket. There is a limitation in his throwing capacity. This should be noted. Also, we should always keep the occupational history regarding the patient's involvement in professional sports or recreational sports, and look for hypermobility. If you can measure the beaten score, check the hypermobility of the little finger, thumb, the elbow, and the knee joint, and try to score it as 1 point for each. If the score is more than 5, definitely then he is a hypermobile patient. And ask for specific mechanisms of injury. How did he develop the injury? If that will lead us to the diagnosis of the direction of the dislocation. Always in physical examination, we're supposed to make sure that the patient has undressed, at least to make sure that the shoulder is visible, to identify any visible asymmetry of the scapula, any visible atrophy of the deltoid, supraspinatus, infraspinatus. We'll have to see from the front and the back. I usually ask the patient to undress himself, at least exposing both the shoulders, and ask him to do an active movement, assessing the forward flexion, rotations, and internal and external rotations. Once I make sure that it is done by the patient, again, I try to evaluate the passive movements. So it is very important that we assess the active movements of the patients and compare with the passive movements and compare with the other normal shoulder. You always have one normal shoulder to compare and see if there is any deficit. So if the passive movement is more than the active, then we should be thinking of a muscle weakness, could be a cuff weakness. We should identify if the painful arc, which is usually between 50 to 120, to look for any instability or impingement, and look for any specific restriction of the rotations, which would lead us to a fixed neglected dislocation, or it could be adhesive capsulitis as well. Simultaneously, we need to palpate specifically on tender points at the AC joint. Many times we tend to miss the AC joint arthritis. Also on the sternoclavicular joint, check for the warmth if there is an associated infection or inflammatory condition. Regarding the specific test for shoulder instability, we would discuss about anterior instability, the apprehension test, crank jobs relocation test. For posterior, usually the posterior apprehension test, the load and shift can be done for both the anterior and posterior instability, and a sulcus sign for a multidirectional instability. So the apprehension test here, the patient is either seated or may lie down supine, and you take the arm about 90 degrees of abduction, flex the elbow to about 90 degrees, and then slowly start from neutral rotation, external rotating the shoulder, and you tend to get a sensation of pain on the patient's face. So if the patient is very apprehensive that it might dislocate, you're supposed to notice that that itself is a positive sign. Okay, a positive sign means the patient has a fear of dislocation. So when you are doing the maneuver, you specifically look at the patient's face. He might wince or he might ask you not to do further external rotation because he has a fear of dislocating the shoulder anteriorly. You slowly take it into 90 degrees of abduction, and from neutral rotation, you start accelerating the shoulder. You can very clearly see that the patient is wincing and is very conscious about the maneuver. Apprehension test is highly specific, but not very sensitive. It has a variable sensitivity. But in combination with the relocation test, it is very highly specific for an anterior instability. This is Crank-Jobs relocation test. This is performed immediately after the apprehension test. If you feel the patient is very apprehensive, what you can do is you can put your palm on the anterior aspect of the shoulder and press the shoulder posteriorly. The patient gets relieved of the pain and he has no fear, which is an indication of a positive relocation test. Same patient, if you see here, first the apprehension test, an abduction, and slowly we have done an external rotation. There is a small subluxation. It again relocates back. So this is very specific for anterior shoulder instability. The same combination of tests can be done in sitting position. Since the patient was very conscious after the first 2 maneuvers, he is very conscious, he's not even allowing me to do an external rotation. So this is a very, very highly specific test for anterior shoulder instability. So it is not necessary that one clinical test is sufficient. We should always do in combination. Apprehension test with relocation test is very specific for anterior instability. The drawer test, you stabilize the scapula with your thumb and the fingers. You place your thumb posteriorly on the glenoid and anteriorly over the coracoid or the glenoid fossa. And then with the other hand, you try to mobilize the proximal humerus anteriorly and posteriorly. If you feel a translation slightly anteriorly, it is more of anterior instability. This test is always done in comparison with the opposite side. This is not conclusively diagnostic of an anterior instability. Here we try to just check the mobility of the joint. It is not very specific or sensitive test, but it can be of some use for your decision making in the surgery. The sulcus sign here, you try to pull the arm lower down. In case of multidirectional or inferior laxity, you tend to see a sulcus sign positive. In this particular patient, it was not there. So in case of multidirectional or inferior laxity, you clearly see a sulcus sign positive. The sulcus sign is highly specific for a multidirectional instability, but might not be very sensitive. The load and shift test is almost similar to the drawer test. Here, you load the humerus either anteriorly or posteriorly, and then check the shifting. If it is about up to 25%, it is normal. More than 25 and 50% is grade 1 and grade 2 laxity. This can be done by applying either anterior force or posterior force. So it can be an anterior load and shift and a posterior load and shift. Here, we just try to assess the amount of joint play. It is not specifically specific assessment for instability. Then in the posterior apprehension test, the elbow is flexed to 90 degrees. With the arm in flexion, you try to apply a posterior force to see the apprehension on the face of the patient. This is indicative of posterior instability. This is also highly specific set, but again, the sensitivity varies. Once you're done with the instability, you always look for other tests to assess the cuff, the biceps, and also assess the neurological evaluation for the supraspinatus, infraspinatus, and the deltoid. In conclusion, clinical tests play a crucial role. There is no single test which is diagnostic or gives a definitive diagnosis. You'll have to always use more than one test. The apprehension, relocation, and draw tests are more for anterior instability. The sulcus sign is for a multidirectional or inferior instability, for load and shift, and a posterior apprehension for the posterior instability. Thank you.
Next speaker, Dr. P. Sivanandar, Superintendent of KGH and Head of the Department AMC and North Andhra Orthopedic Association President. Please speak on radiological evaluation of instability.
First of all, I thank organizers for giving this opportunity to speak about the radiological evaluation of instability of the shoulder. So this is a huge topic. I stick on to the purely about the anterior instability of the shoulder and what are the things are very required, and some of the omissions will be done. And crucial things only we will discuss routinely what we see in the MRI. And I will give you the information that is required to a basic level, because talking about MRI and CT and other X-ray modalities in the X-rays in the shoulder evaluation, it is a huge topic. So I restrict myself to a few things, and that is very, very essential in day-to-day life practice. So with this introduction, just I start my talk on this. Excuse me. So shoulder instability is a common thing in the younger individual and highly active people. This is very important, we must remember, and it is always associated with other injuries like bony lesions, and which are very important to evaluate in the identification and in the protocol management. And the prognosis also depends on this identification of these lesions. So that's why the radiological evaluation is a crucial role, even though the gold standard is the history taking and clinical examination is the gold standard, and radiological evaluation is only supportive and it dictates your treatment protocol. Of these investigations, the commonly available is X-ray. Most of the times we neglect this, but whenever you ask for X-rays, always it is the duty of surgeon to be there to take these X-rays, because some of these X-rays will be taken in the abduction and external rotation views. So position of the limb. So the surgeon must be there. If the instability is there, again, it may recur again, it will produce the instability and it will cause pain to the patient. So definitely the CT have an important role, and every orthopedic surgeon must have a few knowledge about how to read this MRI. So routinely the trauma series is AP and scapular view and axillary view. These three are routinely trauma views, but shoulder instability needs additional important views. These are striker notch view and West Point view and Burney view. These three are important things. So these three will give you some amount of information regarding this. How much specific and how much sensitive also we must know this. So routine AP will tell you the articulation, glenohumeral articulation, and sometimes it will tell you in the internal rotated position. Definitely it will give you the clue that Hill-Sachs is there or not. So once you take the AP view itself will tell you some things. It is true AP is very, very essential. That is called Gracie view. So if you take this, it will give you the glenoid profile very clearly and humeral head profile very clearly. So why I'm saying that, in a normal AP view, normally the humeral head will overlap over the glenoid. In Gracie view, humeral head never overlap over the glenoid. See, if they are overlapping, something is wrong. You must suspect in those things. So routinely, everybody can identify this dislocation, fracture dislocation, and Hill-Sachs lesion. And you can see the bony Bankart and rim sign and light bulb sign that will tell you about the posterior dislocation. And joint space widening, sometimes it will give you the clue. Some other infective pathology also can lead to this particular dislocation, or a neuromuscular disorder can produce this particular dislocation. And Gothic arch is also one of the important clinical signs, radiological sign that will tell you about the instability. And crossover sign. In the crossover sign, in the Gracie view, if the crossover sign is positive, that means overlap of the humeral head with the glenoid. That means there is some displacement of the humeral head out of the joint. You must suspect this. This is the importance of crossover sign. Then how do you take these X-rays? West Point view. So this is a very important thing to identify the glenoid bone loss and how much specificity. It's a specificity is 90 to 100%. So you need not go for all other CT or MRI modalities, and sensitivity is only 70%. So this is very important thing. You can diagnose 70% of the people where is the lesion in the glenoid. So that's why taking of West Point view, it is otherwise called as modified axillary view. So you try to get this X-ray and you can see the anterior glenoid rim fractures in these cases. And Hill-Sachs also can be detected with this. both the bony defects can be identified. And this one is the striker notch view. It is the gold standard to identify the Hill-Sachs defect. The specificity is 91 to 100%. And whenever you ask for these X-rays, please surgeon must be by the side of the patient. This is very important. And Bernay view is another important view that will identify the anterior glenoid rim loss. The specificity is 80 to 100%. So always you need not go for, if the patient is poor, you need not go for CT or MRI. So in simple X-rays also you can able to identify some of the lesions. So you can see the cliff sign or blunted angle sign. You can see there, it is a rim fracture. Next important investigation is CT. CT will tell you the about of the glenoid bone loss and humeral head bone loss, and at the same time, it will tell you other associated injuries. So when the traumatic history is there, definitely it needs CT scan. Normally, the glenoid is pear-shaped. If the bone loss is there, it will appear like inverted PR. So estimation of this glenoid bone loss is purely by the CT scan. Whenever you order for CT scan, you please ask them, ask them to mention about the size of the bone loss in these cases. And if it is a unilateral pathology, definitely you can have a counterpart, the comparison for that. If it is a bilateral means, you have to use that, it is a best fit circle method. You must ask them to give the CT films and on view of the glenoid. So you can able to calculate the amount of diameter of the glenoid and amount of bone loss of the glenoid. The percentage that will tell you, usually if it is more than 25%, it needs surgical procedure, as Dr. Praveen already mentioned about this. So best fit circle method, usually you will do, you ask the CT technician to do this particular job. We can't do this particular job. So you ask them and you can calculate on this about the bone loss. So PICO method and glenoid index method, these two are, Out of these two, PICO method is the best method that will give you accurate measurement. One is with the radius, one is with the amount of bone loss, that is total bone loss of the glenoid will tell you. This is the amount of total bone loss you can calculate with the best fit circle method. Next one is Hill-Sachs lesion. This is very important. Most of the times this is neglected. Once a Hill-Sachs lesion is identified, you must know that whether the Hill-Sachs lesion is vertically oriented or obliquely oriented, as Praveen said. But at the same time, you should know whether the Hill-Sachs lesion is very nearer to the articulating surface or very nearer to the greater tuberosity. If it is more nearer to the articulating surface, it is more likely to have the engagement and it will produce dislocation. And the direction of the Hill-Sachs lesion is also important. If the direction of the Hill-Sachs lesion is directing from the lateral to medial towards the articulating surface, these lesions are more prone to have the engagement and it will produce dislocation. So you have to measure the size of the Hill-Sachs lesion is also important from the lateral border, medial border of the greater tuberosity towards the medial side, how much it is extending. So this is on-track and off-track lesions. That means how the Hill-Sachs lesion is engaging over the edge of the glenoid. So if the size of the Hill-Sachs lesion is not greater than the width of the glenoid, so definitely it won't produce any engagement and it won't produce any dislocation. You see the second picture, there is the glenoid lesion, Hill-Sachs is bigger than the width of the glenoid. So it is engaging. Once you do the abduction, it will engage. So this is called engaging Hill-Sachs lesion. There you have to do the procedures of Hill-Sachs procedures. And this is greater tuberosity, the tracking of the glenoid and the Hill-Sachs interval. These two you have to calculate. If the Hill-Sachs interval is less than track, then there is a on-track lesion. If the Hill-Sachs interval is more than, it is a glenoid track, it is off-track. If you calculate this, then definitely you can able to appreciate. I told you that vertically oriented and obliquely oriented Hill-Sachs, definitely that is important in this. When you take the MRI, you check for all the, I know that all the surgeons knows about this, but most important is T1 weighted images, T2 weighted images, and fat suppression studies. Of these fat suppression studies are very, very important. You must check for that. So always start your examination of MRI from center to periphery. What are the views you will see? Coronal oblique and sagittal oblique and axial planes. Coronal oblique, it is parallel to the supraspinatus, and sagittal, it is the perpendicular to the supraspinatus, and axial planes, it is perpendicular to the shaft of the humerus. So these are the various lesions you can able to identify, but MR orthogram is far superior than the routine MRI. So you see the Bankert lesion, so you can able to identify, this is an important thing, you should know that this is the apex is towards the humeral head and base is towards the glenoid. This is classical in the Bankert lesion, you will see that. So classical Bankert lesion, always you will see the fat suppression side is only you should ask. Then only you will know that whether the fluid is there and it is separating out or not. The pointing apex is towards the humeral head. So this is the glenoid labral articular defect. It is the articular surface is also avulsed here. Once you see the articular surface here, that is avulsed along with the glenoid labrum. This is glad lesion. The prognosis is not that much good. This is the articular surface is also inward. And this is the Perthes lesion. Here the periosteum is intact and the glenoid labrum is avulsed from this area. And most of the times, the apex is pointing towards the humeral head and it is undisplaced. Most of the times this is undisplaced because periosteal sleeve is intact. Another one is Alpsa lesion. It is anterior labral periosteal sleeve avulsion. This is important. One is, it is a free type and other one is, it is the adherent type. You can see this in the free type. The periosteal sleeve avulsion in this periosteum is not intact. But you see that the apex is not there and base is at that level and apex is pointing towards the glenoid. So if the apex is pointing towards the glenoid, it is more in favor of Alpsa lesion. If the apex is pointing towards the humeral head, it is mostly because of the Bankert lesion. So it is the Hagel lesion and it is a humeral avulsion of the glenoid ligament. And here you can see the recurrent dislocation ambry. It is non-traumatic lesions. Most of the times you will see there is no labrum at all here in both the sides. And you can see the inferior axillary pouch. It is a huge pouch is there. That means the inferior glenohumeral ligament is lax. And you can see the anterior rotator interval. There is a huge gap is there. If it is huge gap is identified, that means it is mostly because of the non-traumatic lesions. These lesions cannot be treated operatively. You must ask them to go for the other modalities of treatment. Thank you.
Thank you, Sivanand. That was a very good talk. We conclude this session. Question and answers will be after next session as we are running short of time. Thank you.
I thank all the faculty of the session for their wonderful talks. Sir, sir, first session faculties, I request them to please come onto the dais to receive the mementos. Sir. Sir. Sir, I Sivanand Garu to present the mementos to the moderators of the session. I request the moderators of the second session to come out to the dais, Dr. T. Ramanamurthy and Dr. C. H. Murali Krishna.
Good morning. First of all, my congratulations to the CARE Ortho team and especially team who are involved in a lot for doing this program. Now I request Sridhar to give his talk on OT setup and portal placement.
Long press. First of all, I'd like to thank the organizing team and Dr. Srinivas for giving me this opportunity. And also, I would like to thank and congratulate Armugam sir. So for organizing this extensive program, Indian Arthroscopy Society, like a brainchild Ias One program, we can see for the last 2 years. So now sir has taken it to the next level that it is being organized in different cities in the same day. So today we doing in Vizag, at the same time it's happening again in Jaipur also. So it's going to all 2 and 3 tier cities of across the country where the arthroscopic education platform is being provided to all the cities so that the all young budding surgeons will learn the arthroscopic art and the country will be lot of trained arthroscopy surgeons in our India. So thank you, sir. Thank you so much. And also we all know that sir hosts that CSS center in SRMC. That's a world-class international standard platform where a lot of sports training centers will be there in their CSS and an excellent cadaveric course in SRMC. That will be a regular training program for all the arthroscopy surgeons. So today I'm going to speak about OT setup and portal placements in shoulder arthroscopy. So I'm sticking to basic talk. So shoulder arthroscopy, you should attempt only if you have done a lot of knee arthroscopy surgeries and you can play around with the arthroscopy and do a lot of procedures in the knee. So once you are confident enough, then only you should switch on to the shoulder arthroscopy. Because in the knee joint, except for when you are doing a PCL reconstruction, only things which we can damage is the posterior popliteal vessels. But in shoulder, you have a lot of scope not to do, but there is a lot of scope to damage the surrounding structures like suprascapular nerve, subscapular nerve, axillary nerve, or a brachial plexus injury. So there are a lot of things which can be damaged if you're not familiar with the procedure or the portals or the arthroscopic surgery. So always make sure that you do a lot of knee arthroscopy surgeries, then you go ahead with the shoulder surgery and always with someone along with you. So you already done some surgeries with some seniors or you have some friend or someone who has performed the surgery. So that is the stage where you should start your surgery, but not alone for your first case. So most important part in shoulder arthroscopy is the patient positioning. So unless you are acquainted with the position of the patient, you may not get anatomically oriented. What are the structures you are looking into the joint when you put your scope into the shoulder, and you may get lost in identifying the anatomical structures itself, leaving alone performing any surgical procedure. The other one is the OT setup. So you should be acquainted with the OT setup, the equipment of the surgery and all the instrumentation, what is required for the shoulder. And all these things gives good results in your patients. So what are the principles in shoulder arthroscopy? First of all, the surgeon should know the equipment. So we should be familiar with all the equipment involved and we should be familiar with all the instrumentation involved. We should know what instrument is used for which technique and which procedure, and we should know any equipment, any issue with the equipment, how to correct it and how to operate the equipment. So the OT personnel are not the key person. The surgeon should be the main person, should know how to operate the scope or light source or RF probe or a shaver system. We should be familiar with all these systems, how to operate in case if any mishap happens in between the surgery. And also you should monitor your setup. You should monitor the patient, monitor the vitals of the patient. You should monitor what is happening with the pump and shaver system and all those soft tissue swelling in the shoulder joint. And also you should communicate with the anesthetist, especially if you are doing a shoulder arthroscopy in a beach chair position, where is a high chance of hypotensive anesthesia. And if you're neglected and you keep on doing your surgery for hours together, you may have some deleterious complications. So this is how the OT setup looks if you are doing a shoulder arthroscopy in both positions, if you are doing a lateral or a beach chair position. So this is how the patient should be positioned, with the monitor on the head side and we onto the operating side with the Maya stand and our arthroscopy monitor onto the opposite side. So what are the basic equipment you need for shoulder arthroscopy in your trolley? So you should have a camera, you should have a 30-degree scope, should have a light source, and always we need RF ablation device. So don't attempt any arthroscopic shoulder surgery if you don't have an RF probe. We have a lot of disposable RF probes from the companies where you can just switch on to our regular cautery and use them as our normal cautery, so that if the shoulder joint starts bleeding, so you should be able to control it and you should have a very good visualization of the shoulder joint. Other you may get lost in the bleeding shoulder joint and you get away outside without performing a surgical procedure. The other one is the Sheva system. You should have a very good Sheva system, because especially if you are doing a rotator cuff repair, you may need to bursal surface side, you may need to debride a lot and remove the bursa. So where you need to have a very good Sheva system. So always better to have a pump. It's not a must, but always pump will help you to have a very good visualization of the shoulder joint, especially if you're doing a Bankers or cuff, but especially in the case of Bankers surgery. So you should always get acquainted with your pump and always monitor the pressure of the pump, because if you keep on increasing the pressure rather than using it for a visualization purpose, the shoulder may get swollen up and the portals will be changed and it will be difficult to access your anchor position where you want to access initially. And always we have a lot of things, single, dual wave, so many pumps are available, but it is always useful whatever you are acquainted with. And always make sure the pump is above the patient level. So always wherever you position the patient, whether lateral or beach chair, the pump should be little higher position, so that you make sure that it is in the second trolley or third shelf of the trolley, not in the lowest shelf of the trolley. Shoulder traction device. So always it's better to have a shoulder traction device. So you have again Indian and imported lot of varieties where you can use it. So especially if you are doing for a Bankers surgery, so you will have a very good visualization rather than someone assistant pulling and pushing the shoulder and making us to struggle for the surgery. So Sheva system, again, we have a lot of different Sheva systems available, and always it is better to have a burr which can be attached to the shaver on the shaver itself. So if you have a bony burr, it is always useful if you want to attempt any osteophyte excision or a subacromial decompression for better visualization of the subacromial space. So always make sure you have bony burr along with the shaver. So this is how your trolley looks simple. You don't want so many instrumentations or equipment for a shoulder surgery. You can have a simple trolley where you have your equipment like light source, camera, and IV fluids. The other one, you have a basic surgical setup where you have a straight artery and mosquitoes and Weisinger rod and marker pen. And always better to have a cannulas, whether it is 6 or 8 mm cannulas, depending on the surgery, whether you are doing a glenohumeral or a rotator cuff. Anesthesia plays a very crucial role, especially if you are doing a beach chair position. So always to give a block to the patient rather than doing only in a general anesthesia, because the patient in general anesthesia cooperates much, but in the post-operative, he may have a lot of pain in the post-operative period. So always you can use an interscalene brachial plexus block. And if patient is cooperative, you can do only in anesthesia, where we do all our cases in only in the block. The patient will be lying comfortably in the OT's bed. Patient positioning, again, it's a crucial role compared to the knee joint. Either you can do in a beach chair position or lateral decubitus position. Both the positions have their advantages and disadvantages depending on that positioning, but always make sure you get acquainted only with one position. So if you are a traveling surgeon, if you are doing surgeries in different setup, always better to go ahead with a lateral position, because the beach chair positioning devices may not be available in all the different hospitals, especially you are doing in a peripheral setup. So always better to learn with a lateral decubitus if you are in a different setups. But if you are in only one setup, whatever comfortable you are, you can stick to your position and go ahead with that. So beach chair position, the advantages being you have an excellent anatomical view of the glenohumeral joint. You feel that You are seeing with your eyes into the shoulder joint and you know exact anatomical landmarks when you are operating. And the other important thing is the shoulder joint itself is in our hand, where you can do an extensive range of motion and you can see whatever anatomical point you want to see, because we don't keep it in the traction. The other one is if you want to convert into the open procedure, suppose you are doing a Bankert lesion surgery and if you notice that the bony Bankerts is there or the shoulder glenoid bone loss is more than what you expected and you want to convert into an open Latarjet procedure, you can do so with the same procedure rather than changing the position to the different one. The other one is the versatility of the type of procedures. With this, you can do a lot of procedures. You can do different surgeries, even shoulder fixation or any shoulder replacement, any other positions, you can do that. And other thing is for the anesthetist, it's very easy access to the airway, but it do have some of the disadvantages, the main thing being hypotensive anesthesia. So it's very difficult for the anesthetist to manage the hypotensive anesthesia. Sometimes it may cause decreased cerebral perfusion. The other one is you cannot distract the joint as you're not giving any traction. And especially if you want to do any posterior labral procedures, they have a limited visualization and the position itself is costly. The lateral decubitus position, you have an improved visualization and increased working space. And one advantage is all the bubbles from the cautery, it moves laterally. So you have a very good view of the joint and it has a less complication of decreased cerebral perfusion. But the issue is risk of neurological injury. If you move more medially or more laterally, you may injure the suprascapular nerve or the axillary nerve, and you cannot convert it to the open procedure. You may need to shift the patient again, rescrub and do the procedure, and it may be difficult to manipulate these patients. So these are all the different portals, but being a basic shoulder course, we will emphasize only on the important portals where you want to know when you are doing a basic surgery or an advanced surgery. So depending on the pathology, whether you are doing a subacromial space or the instability slap or acromioclavicular pathology, you need to have a different portals which are very much complicated. But we should learn to have only 3 to 4 portals, where posterior portal, anterior portal, and lateral portal, which can be converted to antero-inferior, antero-superior, and different procedures depending on the surgery. The main key consideration, you should know the anatomical landmarks, you should avoid the neurovascular complications, and you should manage your fluid. So the 3 landmarks which is very important anatomically is the coracoid, which should be marked, and always make sure you do not cross medial to the coracoid, which is a dangerous zone for neurovascular structures. And you should always stay lateral to the coracoid. The second one is the lateral end of the clavicle and the lateral acromion bone. So the only 3 major portals are the posterior portal, which will be a viewing portal, which is done in the soft spot as shown here. The other one is an anterior portal, which is done in the rotator cuff interval. You can divide it into antero-superior or antero-inferior, depending on whether you want to visualize or whether you want to have a working portal for a glenohumeral instability. This is another lateral portal, which can be done for subacromial pathology. You can do it an anterolateral portal or a posterolateral portal, depending on whatever position you want to repair the cuff. So you can manipulate it. And the other one is always you should make sure that you doesn't go much lateral, because you can damage the axillary nerve. The rare portal is an Navier portal, which can be done in between the spine of scapula and AC joint. Thank you.
Thank you, Sridhar, for your elaborative talk on portal placements and OT setup. And now I call upon Aslam Arif for his talk on diagnostic arthroscopy.
I thank the organizers for giving me this opportunity. And I thank Professor Armugam for this wonderful program and making arthroscopy so widely available all over India. I also thank faculty for traveling all the way to Vizag and making this program wonderful. Thank you very much. So this, Sridhar has made my talk easier. For the youngsters who are starting shoulder arthroscopy, I would suggest that you spend more time in getting your OT right and your equipment right. Automatically, the rest of the procedure becomes enjoyable. So we'll start with the diagnostic arthroscopy. Once your when your position is right, you got a proper anesthesia, your equipment is right, and you're starting your arthroscopy. And the portals that you have seen, posterior portal normally is a viewing portal to start off with, anterior portal you use for instrumentation. If you get these portals perfect, then the rest of the procedure becomes easy. Otherwise, then you're struggling most of the time. We missed out on one video. Anyway, we'll start with this video. So once you get your anterior portal in, the first thing that you will see is your long head of the biceps, where the probe is on. When you pull it down and you see where it exits and see whether there are any changes on the long head of the biceps. This is where you start off with. Okay? Then you can see the pulley which is holding the long head of the biceps up. Okay. Come down that, what you're seeing is the subscapularis. Then you're seeing the glenoid. You're traveling down. Proximally up, that is the rotator cuff, supraspinatus. The infraspinatus. You look at the cartilage below the rotator cuff and see that is the bare area. Here you're looking for your Hill-Sachs lesion that we've described now. You're down into the axillary recess, you see the fold of the capsule. You externally rotate and you see the IGHL, glenohumeral ligament, inferior glenohumeral ligament, which has two anterior and posterior aspects. Then you come back again into the joint up, back to the long head of the biceps where you started. Now you're looking, now your scope is in the anterior portal. You're looking posteriorly. You're looking at the posterior labrum. Left side is the glenoid, your right side is the humeral head. You're looking up at the rotator cuff again. Sometimes it is tight and it gives a little internal external rotation, makes your scope easier. That is the posterior labrum that you see. Here now you're seeing the anterior labrum and the capsule under. You're just on the subscapularis. That is the labrum. And then you're seeing the that is the important area that we were describing, where you have all the brachial plexus and your vessels. That is the danger area. And then you are again back over the subscap into the glenohumeral joint. Okay, we were talking a lot about the position where you have a lateral decubitus position, which is easier, and you have the B chair position. Now, most of the times, as budding surgeons, we don't really know what, if we are trained with a particular surgeon who's doing a B chair position, we are comfortable doing it. If we are trained with a surgeon who's doing a lateral decubitus, then we stick to that position. Okay, so for the beginners, we want to see what this position looks like. Okay, we are into the joint on the left side. It is a B chair position. You have you look at the orientation on the left, on the right side. Okay, this is more vertical on the right. On the right side, you can see that it is more horizontal. The glenoid is more horizontal. Okay. So the same portal you're using, anterior portal, you're visualizing the anterior labrum and you're seeing a little tear there, which is more vertical. That is the IGHL into the recess, going up again. So more the number of procedures that you do, the more familiar you will be with the structures inside the joint. Now you can see the slab, the superior labrum. There you are seeing the rotator cuff. You can see a minor tear there. That is the bare area. the posterior labrum, then the superior glenoid, and your longer the biceps. Now, this you're visualizing in your lateral decubitus position. So you can see when you enter that your glenoid is more horizontal, your humeral head is on top, and you just follow the same procedure. Okay. Under surface, you can see the complete glenoid with the pristine cartilage. You can see the humeral head, the rotator cuff. Axillary recess. Okay. So most of the time, loose bodies are in the lower axillary recess. Okay, so once you have a look at all your structures and you know if there is any pathology and you can address it the right way. This is subacromion. It's a kind of, without this, your diagnostic arthroscopy is not complete. And if there is so much of synovitis, there must be some pathology. You're getting a portal, lateral portal. Remove the bursa as much as required, and you can start seeing the rotator cuff tear. Most of the time, this is the subacromial arthroscopy is a little messy. So you have to maintain your blood pressure and your pressure in the pump. You identify the edges of your acromion and decompress a little if required, and then you can plan your repair. This is the lateral side. Now you can see it more clearly. Your rotator cuff tear. If there is a little compression or you feel that you need to decompress, see that there is adequate space post-operatively so that you don't damage your repair. Yeah. Then you complete your rotator cuff repair. And then this is your anterior portal where you can decompress the acromic clavicular joint if you feel that there is, and so that is the decompression of the AC joint. Right? So that basically is the diagnostic scopy where you follow a particular protocol. And so normally what we do is we just rush through this again. We follow a 15-point evaluation program. Okay, that is from the South California Orthopedic Institution. Okay, you start with so the first 9 are in the glenohumeral joint, 10 to 13 is the humerus, and 14th is the subacromial space. First position, when you use a 30-degree scope, you look at the superior glenoid. And there you have the longer of the biceps and your superior labrum. So here you see your tear, so you examine your anchor for the longer of the biceps, and you can see your slap lesions in this area. Then you look at the longer of the biceps, okay? And along with that, you examine your supraglenohumeral, superior glenohumeral ligament, SGHL, which runs along with the long end of the biceps. Then you rotate the scope a little inferiorly to see the middle glenohumeral ligament, which is attached from the humerus neck to the glenoid, okay, in the labrum. Sometimes there is a variant called the Buford's complex, which is it's a cord-like thick consistency. Then you go down a little and examine the subscapularis, as we have seen, the consistency, and into the recess of the subscapular tendon. Then anterior-inferior glenoid, where you have the different lesions that we have discussed, your Bankart's lesion, ALPSA, or you have a Pathy's lesions or different lesions, you will diagnose in this area. And then you get into the recess where you see the IGHL, both the bands, anterior and the posterior. Then you go to the posterior glenoid labrum, and you see your other lesions, reverse Bankart, Hagel lesions, etc. Then you come up posterior superior labrum, where you see the slap lesion extensions. Okay. Then you go up and see the rotator cuff supraspinatus and the infraspinatus. Okay. The capsule, and finally the subacromial space. Okay, where we've seen the procedure right now. Thank you very much.
Thank you, Aslam. Now the time for the question and answers on first and second session. Delegates, come up with your questions. My question to Sridhar, do you have any preference for the rotator cuff, the position on the placement of the patient? Like anyhow, the instability surgeries, we'll do it on lateral decubitus position. But in rotator cuff repair, what you suggest? Rotator decubitus or beach chair?
Better you can do beach chair, sir. But I do personally everything on lateral position.
General consensus right now is maybe an easy way to do the rotator cuff is the beach chair position, and all instability surgeries is the lateral decubitus. For whoever is budding surgeons, maybe they can acquaintise both, maybe a better.
Yeah, it's difficult for them to get organized for beach chair in one surgery and rotator cuff in other position, Bankarts and rotator cuff. So better always to get acquainted with only one position.
Yeah, till maybe they acquainted
That
to
you
that,
can
so
adjust, the
that
traction
maybe
things,
they can
other
switch
things.
to both.
Yeah.
Because the position like in a hip surgery, if you want to go to the lateral and the posterior, both are required.
Right.
Like
Likewise,
the
identifying the
position.
structures gets difficult, and identifying the pathology gets very difficult. So if you keep on changing the positions for different procedures.
Yes, but you want to do a rotator cuff, better go for a beach chair. That is
Yeah.
how, because
Ideally,
in
that is well.
like wherever, like in the shoulder, or the hip or knee, whatever, you should have at least two approaches to deal with the surgeries.
Exactly.
And my question to Sivananda, sir, do you ask for the normal side glenoid also for the measurement of the bony defect in the glenoid side? Because it's very crucial to decide whether to go for the bony procedure or a soft tissue procedure in instabilities.
In instabilities, in the normal cases, usually you will take a glenoid measurements. As a routine, you will take the glenoid measurements. And if you check the glenoid, there is a 0.83% of the track will be there on the glenoid side. That much part is only articulating with the humeral head. So if it is associated with Hill Sachs or any other lesion is there, even the glenoid is normal, appears to be normal, then these patients can have a Hill Sachs engagement in these cases. So routinely normal cases, we need not ask for all these issues, sir. When you are suspecting any engaging lesions only, you will ask the CT scan and all that.
Right. For young patients, maybe a CT and MRI both are right now is recommended. What other faculty throw light on it?
So we must have those things.
Yes, sir.
That is best always. All the investigations, if you are having in your hand, and at the same time the CT technician is knowledgeable enough, and they can get all the off-track and on-track lesions if they can identify and they can do that, then it is a good workup to decide which procedure you want to do it.
Yes, sir. Yeah, please.
So actually, CT scan is a technique of choice. So your question was, okay, do we do opposite shoulder also? Opposite shoulder is ideal, but the technique is called the PICO technique, PICO method, where we compare the opposite side to this side. But we should also remember that there's a 6% difference in between glenoids, even normal glenoids. There'll always be a difference of 6%. But definitely, best fit circle method compared to the opposite side shoulder is described by Dr. Sugaya is one of the methods of choice. Then now for more, there's a technique called Prada technique, called circle line method. It is supposed to be, again, CT based. That's supposed to be the best when we would do a comparison.
Yeah, definitely. But sometimes we'll miss the glenoid bony Bankart, what we miss in the commonly in MRI. That's the reason young patients, if you have a facility, you can ask for the shoulder protocol, like for instability, you can club with a like MRI and CT on the same side. Maybe we don't need a opposite side measurements, as Sivananda told. And I request delegates to come up with some questions. You have another 3 minutes, I think. Any other thing?
My question to Aslam. While doing arthroscopy for the young surgeons, it is very difficult to identify this especially these glenohumeral ligaments. Especially they get confused as to what it is. Can you tell some tips so as to easily identify these structures for the young surgeons?
As you start off your procedures, it's a little difficult sometimes to get hold of these ligaments particularly. But as you start seeing more of these ligaments, they're basically stabilizing ligaments. MGHL normally is quite prominent, and most of the times you can't miss it. SGHL sometimes it is prominent, but if you look at it particularly, you can't miss it. IGHL, you require a little movement of the humeral head so that it tightens when you internally rotate and externally rotate, and that you can see that IGHL. Particularly these, when you have a tear of these ligaments, then you will start having instabilities. And even before you get into the shoulder, MRIs will give you a particular picture that you look into the joint. So that makes it easier.
Thank you, Aslam. Now the Momento's presentation. Sridhar, please come on to the dais. And Aslam also.
Sir, I request Dr. Aslam sir to present the mementos to the moderators.
Now the inauguration.
Hello. Yeah. It's a feast to the eyes to see the entire hall full with all the delegates on this Sunday. So we have 132 registrations for this course. So it's very much encouraging. So I thank Indian Arthroscopic Society for giving us this opportunity to conduct this basic shoulder arthroscopy program. And I thank Dr. S. Armugam sir once again. And as we have seen, sir, there are many young orthopedic surgeons in Visakhapatnam, and everybody is very much eager to learn arthroscopy and become specifically specialized in arthroscopic faculty. So it's again encouraging to people on a Sunday. So this, I would like to invite all the faculty and the dignitaries onto the dais for the inauguration. Dr. S. Armugam Garu, President, Indian Arthroscopic Society. So please stay on this. Dr. B. Uday Kumar Garu. So please on to the dais. Our HOD and former HOD and professor, Andhra Medical College, is the past president of OSAP and is faculty in many PG teaching programs as well. Dr. P. Sivanand Garu, organizing chairman for this course, the superintendent of King George Hospital and HOD and professor, Department of Orthopedics, Andhra Medical College. I invite the office bearers of Arthroscopic Association of Andhra Pradesh, Dr. Arif Aslam Garu, President, Dr. Sridhar Garu, Treasurer, Dr. Praveen Kumar Garu, Secretary, and Dr. Ashish Garu, EC member. I invite Dr. BVR and Verma Garu, Secretary, North Andhra Orthopedic Association. I invite Dr. I. Satish Raju Garu, Consultant Joint Replacement Surgeon, Apollo Hospital, Visakhapatnam. He is our mentor. Since day one, we are in Visakhapatnam. So I invite all the faculty, Dr. Ayappan Nair Garu, Dr. Ramakant Garu, Dr. Chirag sir, Dr. Virendra sir, Dr. Raghavendra. I also invite Dr. Sodan and Dr. Kirtana Garu, Care Hospital. Dr. Sodan is Superintendent of Medical Superintendent of Care Hospitals. Dr. Kirtana is Assistant AMS of Care Hospital. We'll proceed with lamp lightning, sir. Dr. Armugam, sir. Please stay on the dais for a photo. Sir, a request of the Armugam sir to speak a few words. Hello.
Very good morning to ladies and gentlemen. It gives me great pleasure to welcome you all for another edition of IAS One and inaugurating this IAS One Vizag today. And the presidential theme when I took over the IAS as a president is bridging the boundaries. So what I want to do was to connect every nook and corner of India with academia, IAS, arthroscopy, academia, tier 2, tier 3 cities, so that the arthroscopic technique knowledge is available to every young surgeon in every corner of the India, so that ultimately it helps the common man. That was the vision. And since then, we've been doing many programs. And sometime on one day, there'll be about 4 or 5 programs on North, East, South, West zone. And I thank the our members who enthusiastically come forward and organize this wonderful event. Even today, being a Sunday, originally I thought it would be only 40, 50 people, but today about 130 people that do on Sunday. And I congratulate Dr. Srinivasan and the entire team for doing this entire program. And for the young surgeons, the Indian Arthroscopic Society provides a very big platform. It's now 40 years since its inception. Now the membership is almost more than 4,000. And there are many opportunities given by IAS to the members, being a fellowship or accredited centers, or the more recently, we started the Indian Ligament Registry. I request Srinivasan to play that video, please.
We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. I think this registry will help us understand the trends of ligament surgeries that are happening in India and help us in bettering our outcomes in the long run. The Indian Ligament Registry will help Indian surgeons showcase their work on the world stage. Dr. Armugam and his team needs to be complimented for the exemplary work that they have done for the Indian Arthroscopy Society. By setting up the ligament registry, I think they have notched up the game by a couple of points. I again compliment the IAS for setting up the Indian ligament registry.
So this registry is developed by a world-class organization. So all your data is very secure. So one handicap what we see is we have so much of talent, do so much of surgeries, but whenever you go international forum, we're not able to talk on our own materials. We still quote from Western literature. So unless we have our own data, our due recognition will not be given to us in our international forum. So I encourage all the surgeons to use this registry. And not only that, it will be your own individual logbook. Nobody else can access that, including the IAS. So I encourage you to become a member and start using the registry. Very soon we'll be launching the shoulder registry also. So it will be a complete one. And there are a lot of fellowship programs, both inland and international fellowship programs available. You all know Dr. Gopalakrishna Fellowship, Kasam Fellowship, and now recently we launched IAS Khan Coimbatore Inland Fellowship. And I'm working seriously getting international fellowship along with ESCA IAS Fellowship, online with ISACAS or ANA Fellowships that will be hopefully will launch soon. So I encourage people who are not already a member to become a member of IAS, and there is very simple, you can do it. There is an online scan which is kept outside the surroundings. You can scan and become immediately member. Also during this tenure, we have increased number of accredited centers for you to do the fellowship, so that you need not travel far away from your home. You can choose a center which is close to your home and do accredited fellowship. Also, I request the other senior faculties to make your centers eligible to other younger surgeons to come and do the fellowship. You can just simply apply to the Indian Arthroscopy Society accredited centers. So with this small talk, I wish you all the best and enjoy the program. Intense vibration, also a little bit of fun. And once again, I congratulate the team. I call three musketeers: Srinivasan, Rajesh Reddy, and Santosh. And an interesting aspect I learned, the three each do one specialty, and Rajesh Reddy and Santosh doesn't do arthroscopy, but they came together and put up a good show. This is also a lesson for the younger surgeons. You please get into a group practice that makes you learn more, do more. Also, you can take time off from your work. So with all this, I wish you all the best. Jai Hind.
Sir, I request organizing chairman Dr. Sivananda Gara to speak a few words.
So, the respected my teachers and my colleagues and dear friends and respected faculty who came all over the areas by sparing their valuable time on Sunday for this wonderful IOS program. So I congratulate, first of all, IOS organizing this academic event in Visakhapatnam, who is very keen and instrumental in this particular organizing these things. Dr. Armugam sir, we are always immense thankful to you for giving this particular opportunity. And Dr. Srinivas and Santosh were very important key role by having this particular program in our city of destiny, the beautiful Visakhapatnam. So definitely with full hall, that is 100 entries in this, in our orthopedic society. So I must congratulate our orthopedic surgeons who are here, they are the future younger generation is taking the torch and going to the forward to conduct all these important academic events. So I appreciate the things. And we are all one, sir, Arumugam sir, and IOS team. So at any time, North Andhra Orthopedic Association is ready to take part in any activity. And I can say that North Andhra Orthopedic Association can take any conference, and we are ready to organize, and we are all one. We unite together and we will conduct all these things. So such wonderful programs in future, you please conduct these such academic activities, because young surgeons are now, they are developing and they are very good. I can say that they are far better than us. On the stage, I can say this word, they are far better than us and they are well advanced, which I want. Most of the times, I always thought of the younger surgeons must be elevated, because in future they can be a very good surgeons and the better things, and they can deliver better services for the nation. I can say, Jai Hind.
Sir, I request Dr. Aslam Arif sir, President Orthopedic Association of Andhra Pradesh, to say a few words.
Thank you very much, Srinivas. On behalf of the Arthroscopic Association of Andhra Pradesh, I'd first like to thank Srinivas, Rajesh and Santosh for organizing such a wonderful conference and packing up the whole room on a Sunday morning for a shoulder arthroscopy which is least understood and least interested even in arthroscopic surgeons. The second thing is that we would like to thank the IAS wholeheartedly for supporting AP in our ventures right from the time of registration and to organizing IAS One conferences. And we've been lucky to have 2 conferences in 1 year. First the knee, and now less than 2 months we've had the shoulder. So thank you very much, sir, for encouraging us and giving us all the support in terms of expertise and infrastructure. It is now my duty to encourage all the young surgeons of North Andhra, Andhra Pradesh, and who is here to take up this opportunity. If the IAS is coming up and helping us, why not we take a step forward and make it bigger? So please, if you have not registered, I would encourage you to register for the IAS in Arthroscopic Society. Okay? And not only that you enrich yourself, but you will have more kind of expertise in terms of arthroscopy, and encourage this. We've seen past 3 years that there has been almost a 30% increase in the procedures being performed in Vizag. So if there is this kind of 30% is a huge number. Vizag is going to develop further, and it's for you to make it a world-class infrastructure for patients to come down not only from AP, but surrounding Orissa and Chhattisgarh. So please take up this opportunity. We don't have dearth of expertise that we see here, world-class. You don't have to travel abroad. We have mentors, we have tutors, we have professors who can give us the same expertise and infrastructure support. So why don't we just grab it with both the hands? Thank you very much, sir, again. And I thank the faculty also for traveling and giving us this opportunity to witness a wonderful program. Thank you very much.
Sir, I request Dr. S. Arumugam Garu to come up onto the stage to say once again that we are all thankful to IAS and Dr. Arumugam sir. We would like to felicitate him. Sir, I would like to invite Dr. Sridhar Garu, Dr. Ashish Garu, Dr. Praveen Kumar Garu, and Dr. Arif Aslam Garu to do the felicitation. And these 4 have been the forerunners of arthroscopy in Visakhapatnam, and they've been conducting good conferences previously. They've been inspirational to all the younger generation. I request Dr. B. Uday Kumar Garu to come onto the stage.
So sir has been our professor in HOD. So and
HOD for many of the young surgeons in this hall. So we would like to felicitate him as well. So please.
Faculty and also in the city now, because most of our seniors have not come, my teachers, and I'm very proud and privileged to see that my own students, my dearest postgrads now become consultants and specialists. They are organizing this IAS workshop. I'm really proud of them. Hearty congratulations to the organizing team. And most of them has become the faculty also. The other day, he conducted one live surgery in one of the conferences. And I see Sridhar. When Sridhar was working in some of the port trust, away the selection committee. I am really proud of you, Sridhar. So I am really fortunate. I feel really fortunate that I was in the selection team when you joined the port trust. And I see my colleagues, professors doing one excellent work. So many friends are there. I belong to a very primitive generation. Primitive, I call it my bridge generation. I have seen the most primitive surgeries and the developing surgeries during the bone and joint decade 2010 to 1 to 10, that is the bone and joint decade, where most of the developments have come. Then the most advanced also we are witnessing now. So one day I still remember one of my colleagues purchased an arthroscopy set and he put it in an exhibition. He conducted it as a program. All of us went to Gazuwaka to see that instruments only. So that was just I was joking with my arthroscopy surgeon. We are interested, we are not the people who like to peeping through the window, keyholes. We want to open the door and see. That just was joking. But it has done wonders. So restore the anatomy, restore the function. Through the small window, you can see entire things. That's a very good advances in all branches of orthopedics. With these few words, and once again, thank you for my dear students for making me part of this program, giving this opportunity. Thank you very much.
I request Dr. Shyam Prasad sir to Murali Krishna Garu and Dr. Pathoanatomy Garu to come onto the stage for the felicitation program. So I also request Dr. Ramanmurthy Garu to come onto the stage. So with this, we would like to start the third session. So I would like to call upon the moderators of this session, Professor Dr. P. Shyam Prasad Garu, HOD Geetham's Hospital, and also Dr. M. Padsad Garu, in charge professor and HOD Department of Orthopedics, RIMS Srikakulam. OTs.
Good morning, all. Now I request Dr. Chirag to present his talk on clinical decision making in instability. Chirag is an ex-associate professor from BJ Medical College and he is presently the orthopedic surgeon in Joint Care Arthroscopy Center in Ahmedabad.
Good morning, everyone. Thank you, Team Vizag, for the invitation. So I will be talking regarding clinical decision making. So it is not an investigation based, but from clinical history and examination, you will get some insights to decide what to do in shoulder instability. Of course, we need to and have to do investigations, radiological investigations for the patient, but before that, there is some insights you can decide what could be done depending upon the clinical findings. So there is a long list of history and how they will help in deciding the treatment plan that we will come through. So per se, the patient is of 18 or 19 years of age or 20, and he is having first episode of dislocation. He is likely to have the second episode. So more than 80% patients will have recurrence. So our decision to repair the torn structures or to stabilize the joint should be earlier. If we let them dislocate in future, then there will be a lot of bone loss and tissue damage, and the index surgery will be difficult with less optimum results. Old age, per se, more than 50 years or more than 40 years of age group, they are most of the time they are having rotator cuff tear. So you should always address the rotator cuff. You may or may not address the labral pathology in these patients, but the cuff tear should be suspected in this age group. Again, the male are having higher incidence, the female are having more hyperlaxities. Now, sports is an important aspect in any instability. So contact sports like in India, the kabaddi or judo or some kinds of fights, they are having higher recurrence rate. So you should always address them aggressively rather than let them dislocate frequently. Now throwing athletes, they are having the inherent and acquired excessive external rotations. So they are having micro instability. So as Dr. Virendra says, that they will feel pain and inability to throw. So that are the indications that they may have some kind of labral pathology going on. They may not have frank dislocations, but these are the symptoms. And again, in treating the frank dislocations in throwing athletes, you must mind that you should not over constrain the joint, otherwise they will have loss of external rotations and they will have difficulty in throwing. So this is the Neeraj Chopra, the well-known celebrity in javelin throwers. Gymnasts, again, they are having most of the time hyperlax joints, so you should address accordingly. In-season dislocation. Now, the sports person is dislocated, he has dislocated during the season of the tournament or match, and this is Rohit Sharma relocating himself, but the season, if it is very important, you can allow them to play during that season, but they are usually higher recurrence rate. So as soon as season completes, you should take a call and repair or address them. Again, manual laborers, they are having a lot of heavy work to do. So always provide them with the robust and most strongest kind of repair. Even if small bone loss, you should address them with bone block procedures rather than just soft tissue procedures. Again, trauma, mode of trauma is important. Whether it is significant or it is trivial. So if it is significant trauma, then it suggests that yes, his joint was stable. If it is trivial trauma, it suggests that the patient might have a hyperlaxity or some sort of lax shoulder pathologies that can lead to first time dislocations. Obviously, recurrence will be afterwards. Again, the electrocution and conversion, these are the entities where you can suspect to have the posterior dislocation, which is most common with electrocution, but it can be anterior dislocation. So the posterior dislocation should be kept in mind in those patients who are having history of electrocution or conversion. So number of dislocations and frequency, they also matters. So if there are more than 3 dislocations, you should consider that that patient might have some sort of bone loss on glenoid side or humeral side or both the sides. So always suspect bone loss in larger numbers of dislocations. Slip dislocations, again it is very suggestive of soft tissue as well as bony compromise in shoulder joint. The reduction maneuver is also important. Some patients will come to you and says, I have had to go to the orthopedic surgeons to reduce my joint in last episode, and after few episodes of dislocation, they will be able to reduce themselves. So that suggests the elastic elongations of the soft tissue capsules as well as some sort of bone loss. The frequency, certain patients will have dislocations, say after 1 or 2 years of first episode, they will have again second episode of dislocation, and they will complain, since last 2 months I am having very frequent dislocations. So the frequency, recent increase in the frequency will give some hints regarding the bony and soft tissue compromise. So direction of dislocations is again important. The anterior dislocations, which is most common, that is anteroinferior. The inferior dislocation, which is rare, but it is there, where there is an hyperabduction and external rotation position during trauma, and those patients who are having inferior laxity, they may have inferior dislocation, and those patients with inferior dislocation, they are having higher chances of axillary nerve damage as well as sometimes vascular damage. So inferior dislocations, always suspect some sort of nerve injury or vascular injury. The posterior dislocation, again, there are two varieties. One is posterior dislocation and the other is posterior instability. So posterior dislocation is common in, as I said, electrocution. The posterior instability is common in other sort of group of patients like throwers or the heavy gymmers who are doing a lot of bench press. So they will have some sort of pain which is not exactly defined, or some patients will have difficulty in sporting. So previous surgery, if patient had undergone previous surgery and it is failed, then also you should mark it the index surgery time, whether there was a recurrence due to severe trauma or it was just trivial trauma, the number and type of anchors used and position of anchors, the primary pathologies addressed, and quality of capsule, and how robust was the first surgery repair. So this is the patient, this is the examination finding. Can anyone tell us what is wrong? So it was neglected posterior dislocation which came to us, and you can just on the examination you can find the exact pathology which is missed even sometimes on the X-rays. This is another patient who was referred to me for surgery for dislocation, and he was having, you can see what is wrong. He was having the brachial plexus rather than axillary nerve palsy, which should not be missed on before jumping straight on the surgery. So this is another patient. You can check the external rotation in different angles. So it is arm by side, 30 degrees, 60 degree and 90 degree. So if patient is having apprehension in mid-range, say between 30 and 60 degree of abduction, that suggests the significant bone loss on the glenoid side and humeral side. So mid-range apprehension should suspect the bone loss. So again, hyperlaxity is another thing you should always look for. Those patients, this is the Baton score. I think everyone knows. I will not go into detail due to time constraint. This is sulcus signs, which suggests inferior laxity. This is excessive external rotation of the shoulder joint. So all these are the things suggesting hyperlaxity. Ehlers-Danlos is again another entity which patients are having soft tissue problems since birth. So it is a genetic disorder, and dislocation surgery in those patients with poor capsular tissue and connective tissue are going to fail. So you should consider these patients, you should plan something like a DAS procedure or something to augment the tissues. Again, beware of the habitual dislocators. Habitual dislocators, whatever you do, they will keep on dislocating and your surgery will fail. So be cautious in treating those patients. Thank you.
And next I invite Dr. Ias V. Nair, since he has got a surgical demonstration. We have just changed the schedule. I request him to please come over and speak on surgical tactic for instability management. Before he starts up, I just want to add up one point for the clinical examination for the youngsters, that what you see the patient in the clinic or your office is entirely different you will need to get him to see what is happening in his activity. So sometimes you may have to go to the ground to see when the bowler is bowling and to see, because most of the time subluxations are well missed.
For this opportunity. I'll be speaking on Bankart repair, which is one of the most common surgeries in shoulder dislocation. And what are the tips and the tricks, what we should remember when we're doing this particular surgery. There'll be other talks on the remplissage and other procedures. We'll have more live surgeries as well. But I'll try to keep it very simple with less of theory, and we'll have more of discussions. So we have published this paper on short-term analysis of Bankart repair, remplissage, and rotator interval closure. So we did a 2-year follow-up of 48 patients. And what we found was, luckily our results have been pretty good. We found that, see, one of the most common a patient is going to ask us is, doctor, are we going to have external rotation deficits? So if you do a surgery properly, and if you do a proper rehab, the chance of having an external rotation deficit is very, very less. So you can see that out of 48, only 2 patients had, that 4% had external rotation deficits, and only one particular patient in this group, 48 patients, had subluxation. So to say that surgery is pretty successful, and it's very, very successful if you do the surgery properly, and the most important thing before the surgery is the patient selection. So you've heard of the previous speakers speak about the type of patients, what are the indications for the Bankart repair. So we should know that the most important thing in success is the patient selection. So what do you mean by patient selection? Patient selection means if you have a scoring system called the ISIS scoring system. To put it in simple terms, a professional athlete, a contact athlete requires a Latarjet procedure and not the Bankart. The Bankart might fail. Bone loss, significant bone loss. What is significant bone loss right now? 13.5% in basically contact athletes. So in your practice, you can either keep 13.5 or 15% as a significant bone loss. If bone loss is more than 15%, you should do a Latarjet. Don't do a Bankart repair. Then next question is, should you do a Bankart with remplissage? Is remplissage important? Now, as in this particular paper, there have been recently a lot of papers coming out that if you do remplissage, invariable of your the tracking is a very debatable concept, because you heard of track, you heard of 0.83%, how it tracks and all that. So that is, that tracking basically means that after your repair is done, if you take your hand into extreme abduction external rotation position, will it dislocate again? That is basically the track. So Itoi has come out with the concept of track. But the thing is that this track is not going to hold. It is not a definite 100% concept. Means even if you try to track it after a dislocation, imagine the amount of force. Suppose I'm moving my hand into extreme this kind of force with a basketball or volleyball or something like that, it will still dislocate. So what I'm trying to tell you is that the tracking is not an absolute concept. So here, what I'm trying to emphasize is, if you want to reduce your chance of dislocation, it is better to do remplissage in all cases of Hilsage. So Bankart with remplissage is what I would advise. Then Coming to the portals, what are the regular portals we use? So I think the previous lectures have focused on the different portals. We use the posterior portal for visualization initially. Then you have the anterior portal. You can see the anterior portal here. Then for me, I will use an anterosuperior port or a transcuff port for a better visualization. Because here, I would like to see what is happening into the anterior part of the glenoid. So I'll try to play this. Here, this is how I put a transcuff port, which is slightly behind the biceps and maximum medial. It comes to the muscular part of the supraspinatus. You can see the spine needle coming in. And then once I mark it with a needle, then I come with a blade, and then my Bissinger rod would come in, and through this, okay, my camera would go in. And that definitely gives a wonderful visualization, the kind of visualization you get onto the remplissage, the Hilsach area, as well as on the glenoid is really awesome if you can use the anterosuperior port as your viewing port. Next, the next step, what do? I do a remplissage procedure. So remplissage, I do invariably in all cases, and preparing the remplissage is very important because you need to span out this. Suppose it is a huge Hilsach, I definitely put sometimes 2 anchors or 3 anchors. Span it out nicely, and your bites, try to keep your bites towards the tendon as much as possible. That means towards the lateral. If you try to take bites much more medial, that means towards the muscle belly, then there are more chances of external rotation tightness. Then elevating the labrum. So when that is done, you can see the anterosuperior port, how we are visualizing the labrum. See, that elevation is very important. Next question is, from where to where do you elevate? You have to elevate all the way from superior, starting from 2 o'clock position, going all the way up to 7 o'clock position. You have to elevate it so much that, how much do you elevate? Till you visualize the subscap belly. Subscapularis belly should be visualized. That is a proper elevation. And how do we know we have elevated enough? Once not leave the belly, so you should be able to really plicate. You should be able to take this capsulolabral complex and really pull it on. That is a proper elevation. Next, where is my first anchor? My first anchor is always going to be a 6 o'clock anchor, because in inferior plication, what is the idea of this Bankart? Bankart basically means you are doing not only just tying up the labrum. That's the last part of it. It means a volumetric reduction in your glenohumeral joint space. You need to reduce space inferiorly, especially, and more anteriorly as well. So you tying up anteriorly is not enough. Just the IGHL is not enough. And inferior plication, that inferior recess should be reduced. So that's very important part of our shoulder stabilization. Because if you think about it, what is the most common dislocation? It's antero-inferior dislocation. So not only anterior correction, inferior is also important. So my first anchor is always 6 o'clock, and my plication will be at 6:30. That means I'll pass the sutures through 6:30. And after this, the most important thing is we should know where to put the anchor. Do we put it on the side of the glenoid, on the face of the glenoid, or on the cartilage? Where should you put it? Never put it on the cartilage. Try to put it on the bone surface. That means you need to elevate or remove a certain amount of cartilage away from the bone surface. That means the glenoid should be, you can see the curette coming in now. I'm using the curette and I'm actually taking 2 millimeters away. You should know that soft tissue heals onto the bone and not onto the cartilage. So if you are waiting for some repair to happen or healing to happen, that healing will happen only between the capsulolabral complex and the bone. So it is important that you curette, remove a particular amount of cartilage so that the tissue comes and heals onto it. Then this anchor has to be on the glenoid face. Only then it will plicate on top of it. If you put it on the side, you will not get enough plication. Then this is again, so I'll show you in the live surgery as well. Here I'm taking the scorpion and I'm seeing the reducibility, see how much I'm able to capture, and also you can see how I'm holding the IGHL there, seeing how it is coming on. Then this is the anchor placement. My 6 o'clock anchor is already here. You can see that I've already placed it. And now this is my, so this is my 5 o'clock anchor, Because why is 5 o'clock important? Because in this 5 o'clock is my double load anchor. You can see the anchor now. It is normally my double load anchor. I normally use tapes. Tapes give you excellent plication. Cutout of the capsule with tapes is almost zero. If you use a wire has more chance of cutout. So you can see how the scorpion is used to pass it deep bites, mattress bites. I usually take it much deeper in, and then you pull it through. So you can see that I'm using a double loaded tape. So out of this double loaded, 2 wires will be used as mattress. And the other one I might use as a simple or as a mattress. You can see how it has been passed. Yeah. So tapes and the mattress suture really help in plication of these tissues. Suppose, what about hyperlaxity? If I find there is more hyperlaxity and the tissue quality is not good, what do? I do a double row. You can see that I've been using, in this particular case, I've used a knotless suture for a double row. So double row helps you in even more plication. You can see the amount of plication, and you can see how the head is centered once you have this double row repair. And my last anchor would be around 3 o'clock position. And again, I will use a mattress fashion or a simple fashion there to basically repair it. So you can see that the head becomes quite a bit centered once you do this. And especially this anterosuperior port will actually show you the actual position of the head on the glenoid. And I'll just skip it. It's the final repair being done. And then in my practice, to increase the success of the surgery and to reduce the redislocation rate, in patients less than 30 years of age group, because in more than 30 years, as the patient becomes older, there are more chance of stiffness. I always do a rotator interval closure. So RA closure, I always add into my practice, where what we do is you can see that thread is passed through the subscap, then it is passed through the supraspinatus, and then we tie it up anteriorly. So this reduces your anterior. That's what I was saying, that Bankart is basically a volumetric reduction. So you need to really close up the space anteriorly. In spite of this, again, the question, I put up the paper first because the question would be asked was, will there be external rotation tightness? Actually, no, that's the answer. This is again rotator interval closure. You can see the rotator interval getting nicely closed up there. And lastly, once you finish all this, you complete your remplissage. So this is my tips and tricks of Bankart repair. Thank you so much.
Thank you, Ayappan. Now I request Dr. Ramakant to present glenoid bone loss in anterior instability. Dr. Ramakant is an associate consultant in arthroscopy and foot and ankle surgery in Ganga Hospital. He has got 30 to 40 publications and he authored 7 book chapters. Ramakant, you can continue with both of your talks.
Yeah, sure. Sure, sir. First, I would like to thank Arumugam sir, Santosh, Shivanand sir, and Rajesh for this opportunity to share. And also, I would like to make it little clear regarding the bone loss and the concepts of tracking with some good videos and simplify it with my talk. So in this talk, glenoid bone loss, humerus, Hill-Sachs bone loss, the time concepts of evolution of the concepts that is engaging and non-engaging by Burkhardt to glenoid track by A.G. et al. And on track, off track by Giovanni. And then options for this. So 86% of recurrent bone dislocation has the humeral defect and glenoid defect, and 94% has the Hill-Sachs defect, and combined bipolar, that is glenoid and humerus, is about 81% in the recurrent dislocation. So what happens during the antero-inferior dislocation? So during a dislocation in abduction and external rotation position, the humeral head hitches against the antero-inferior glenoid and thus causes the compression in the humeral head from the antero-inferior portion, and then causes the bipolar lesion. So, and how the shoulder movement is important is in the mid-range, the glenoid bone provides stability by negative intra-articular pressure and stability ratio, and in the end range, humeral head and the ligaments provide the stability for the shoulder joint. So the glenoid bone loss can be of two types. That is a fragment type, that is a bony bankard, or a erosion bone loss, or the chronic type. So the two types of glenoid bone loss are fragment type, when there is a capsule strong and has a good strong quality. So then the bone gives So, and the mechanism of injury is slightly different. When the capsule is strong and there is an abduction, it causes the bony bankard, and when there is a erosion from the adduction portion of the injury, so it causes the compression in the humeral head and the anterior glenoid rim, that causes the erosion in the recurrent dislocation and the bone loss in the antero-inferior rim. So various methods of measurement were already spoken by Dr. Shivanand sir. Well explained. Pico method is most commonly used, and Hill-Sachs, it's very easily identifiable from the CT and also from the striker notch view. The X-ray shows the depth of the Hill-Sachs. Not only the depth is important, but also the width of the is important. Where is the angle of inclination of Hill-Sachs, or whether it is medial or lateral, is also important in determining the Hill-Sachs lesion. And whether to know the engaging or non-engaging, it was popularized by Burkhardt in 2000, which is combined Hill-Sachs and the glenoid defect. When the Hill-Sachs is small, as you can see here, and it doesn't engage in the abductional external rotation, whereas when the Hill-Sachs is large, it engages, and when the Hill-Sachs is small, it does not engage it. Okay, so what is glenoid tract? So basically glenoid tract is nothing but the blue zone, what you can see there in the humeral head. So where the glenoid tracks during the abduction and external rotation position, and the glenoid tract moves from inferior to posterolateral position of the humeral head. So this is how the glenoid tracks when the arm is in motion, the contact zone where the posterior margin of the humeral articular surface, and from infromedial to postero-superior region. And this the blue zone is a glenoid tract. It is nothing but it has a 83% of width of the glenoid. So that forms the glenoid tract. So it was popularized by A.G. et al. In 2007, where the contact zone of glenoid on the humeral head during the end range of motion, and this is the glenoid tract concept which we has popularized, and then when it dislocates, it forms the Hill-Sachs. So this measurement is very simple. The glenoid tract measurement, the diameter by 0.83 is nothing but the 83% of the width, and minus the defect area, and the Hill-Sachs interval is nothing but the Hill-Sachs region. So when the tract is more than the Hill-Sachs, then it is the on track. So that is small Hill-Sachs. When the tract is less than the Hill-Sachs, then it is a large Hill-Sachs, then that goes for an off-track lesion. So this is the example where there is a blue zone. Here we can see that the Hill-Sachs is smaller, the tract is larger, so it is on track. The Hill-Sachs here is larger and the tract is smaller, so it is the off tracks. So this is the concept of on track and off track. So here once the head is dislocates and the heel sacs is smaller, so it is on track because the track is larger. And similarly, when there is a big heel sacs, and the track is smaller, then it goes for a off-track lesion. So this simplifies the on-track, off-track and the track concept. So what are the surgical procedures for these? So soft tissue procedures, just for 0 to 13.5% soft tissue procedure alone is sufficient. Bankard's repair. Soft tissue or bony procedure for the gray zone, that is what's called as subcritical bone loss. That is between 13.5 to 20%. And of course, all the procedures are needed for bony procedures are needed for more than 20% of bone loss. So what are the procedures? 20 to 25%, we have Latajet or a bone block procedure, that is iliac crest. So for a gray zone between 13.5 to 20, we can go for Latajet or DAS. It's nothing but direct anterior stabilization where biceps is put into the anterior surface. And for less or no bone loss soft tissue procedure with or without remplissage based on track or off track. So the subcritical bone loss, direct anterior stabilization or the glenoid transfer can be done, which can be done arthroscopic or open. So again, the subcritical bone loss, just I'll quickly rush through the slides. Of course, we know for a glenoid bone loss, for critical bone loss, that is more than 20 to 25% of bone loss, coracoid is a gold standard, and newer procedures are coming up where we can use iliac crest graft or a distal tibia allografts can be used. The spine of scapula, the autografts can be used, or a distal clavicle also has been used. Okay, so and for subcritical bone loss, like for 13.5%, this is the new kid in the block where long head of biceps is rooted through the subscap and then attached in the anterior aspect of the glenoid. So the biceps is taken out and it has been attached at the 3 o'clock position. So these are the implants. These are the instrument techniques which has been reported. I don't have the experience, but these are the new procedures which are available for the subcritical procedure. It is called as DAS. It's nothing but direct anterior stabilization with the biceps. So it gives a triple soft tissue block, that is a direct block, and tension for the subscap during abduction and external rotation, and it is also called as a labral reconstruction. So for, of course, for the large bone blocks, we have a gold standard Latajet procedure. So it can be done as a congruent arc as well as to recreate the congruent arc. It can be done arthroscopic or open. This is a common procedure. So the next one is the iliac crest bone. It's very simple. It can be done arthroscopy also. The iliac crest is transferred whenever it is more than 20% or more bone loss. So the iliac crest is called as hidden hibernate procedure, where we can use these cortical buttons or just fiber tapes, and the cross-link systems can be used to fix the iliac crest bone grafts. So I'll just share one case example from our institute where we have done iliac crest graft. So this patient, 29-year-old, with history of fall. 1 year back, he had total 5 episodes of dislocation. He had a sleeve dislocation, and these are his preoperative movements. He had a apprehension positive at 45 degree and also at 90 degrees. And his CT measurement showed that he had about 22.5% of bone loss was there. So for him, we did arthroscopic hidden hibernate and Bankards plus remplissage. So all the 3 was done. So these are his arthroscopic pictures. The rotator interval needs to be cleared first, because when we put the iliac crest through the rotator cuff interval, the lot of soft tissue might come. So the rotator interval clearance is important. And this was engaging heel sacs. So where we can see that the heel sacs was larger and the track was smaller. So first was for the heel sacs, we did a remplissage procedure where double loaded anchor was inserted and bites were taken through the infraspinatus at 4 different directions, and then it forms a beautiful parachute like bites into the infraspinatus. and then the remplissage was not tied after the iliac crest transfer and the labral repair, the remplissage was tied. So here we can see the mobility of the labrum with the bone loss. So I'll just quickly finish this talk. So here we can see that glenoid preparation is very important. So we need to get good bone-to-bone healing. So we are doing a iliac crest transfer onto the glenoid neck region. So bone preparation is important. And first we put that 530 position anchor and then take bites into the labrum and then park it in the posterior portal so that once we put the bone, then we can do this repair. So we just take the bites across the labrum first and before transferring the iliac crest. So these are the jigs which are used for drilling the tunnel from posterior to anterior to get the iliac crest fixed onto the glenoid neck. So here we can see the jig is passed from posterior to anterior. The two tunnels were drilled in the glenoid neck region, one anterior, one superior and one inferior, and then the suture shuttles were passed through this, and through this suture shuttle, the fiber tapes were taken from posterior to anterior, and then the same fiber tapes are passed into the iliac crest in this fashion, and then this suture is shuttled back into the inferior tunnel and then taken posterior like this. And then once we pull those fiber tapes from the posterior, the iliac crest gets seated along the antero-inferior portion of the glenoid. And then we use this cross-link sutures and then tie it posteriorly. So this is implant-less, and then it gives the iliac crest transfer. It's very a simple procedure. Only thing is we need to be little experienced with the shoulder arthroscopy. So then after that, then we can do the labral repair. So we can see the reducibility of the labrum, and then the labral regular labral repair, and we can do it on the margin so that the iliac crest becomes extra articular. And then the bone is extra articular, and then the labrum is repaired onto the margin. And then the remplissage is completed here. So these are our post-operative protocol strengthening exercise from 3rd month onwards. And this is a 6 months follow-up, good incorporation of bone-to-bone healing and recreation of the glenoid. And the graft position is good. There is no malposition, and there is no graft resorption and increased glenoid bone surface. So these are his movements, absolutely full range of movements after 6 months and negative apprehension test. So the take-home message is 0 to 13% just soft tissue procedure like Bancards and remplissage. For critical, subcritical bone loss, we have options of all the three are there. And of course, for more bone loss, Latajet or iliac crest is the option. Thank you very much. So I will continue with my second talk as well. So this is very simpler talk and simple procedure, remplissage. So remplissage is done for the Hill-Sachs defect. Okay, once again, I thank the organizers for this opportunity. So remplissage and Pfizer score. So what is Pfizer score? So I'll be telling you now. So Hill-Sachs, we know that it's a postero-superior humeral defect. So 47 patients in the first time dislocation itself has, and around 90% in the recurrent dislocation. So Hill-Sachs lesion is when there is a dislocation, there is a compression of the rim onto the humeral head, and the repeated dislocation, then the Hill-Sachs gets deepened. So remplissage is nothing but filling. So in French, it means that it is a filling. So with what we can fill with the infraspinatus tendon. So that is what is a remplissage. So Purchase et al. Described the remplissage procedure, and Burkhardt popularized it in 2000. It helps in reducing the recurrence by not engaging the Hill-Sachs onto the defect. So the bony intra-articular defect is converted into extra-articular defect by filling with the caps. It is also called as capsulodesis or infraspinatus tenodesis. So the remplissage is nothing but in French, it is means the filling. So with the external rotation, we see that it no longer engages onto the Hill sacks. So the engaging, as I told from Burkhardt popularized it. So the same video showing the Hill sacks, and it is not only the depth is important, but also the width of Hill sacks and also the inclination of Hill sacks, and whether it is medial or lateral is important to know. And when the Hill sacks is smaller, then there is no then the track is on track, and if Hill sacks is larger, then it is off track. So this is a shoulder position which we do all our bancards and remplissage procedures. The steps in remplissage, as I showed in the previous video itself, here a double loaded 5.5 P cancer is inserted into the Hill sacks region, and then bites were taken through the infraspinatus and then parked it in posteriorly, and then we have to complete the bankart, and then we have to tie the we have to complete the remplissage after. So this forms the parachute like bites were taken. We can see that it covers the whole of Hill sacks defects. And after the bankart, so this is how the Hill sacks defect is completely covered and made extra articular. So for a large Hill sacks, Ku et al. Has described double pulley technique where he has used the two anchors. So for a broader and bigger Hill sacks, we can use two anchors. And this is from the subacromial view. We can see the knots as well. Otherwise, we have to put the knots in the blinded position. So the two anchors are inserted, and then the large Hill sacks is covered. And this is viewing from the subacromial region, taking the scope and then viewing it from subacromial region and intra-articular region. So both we can see that the Hill sacks is completely covered. So now what is Pfizer? So we want to know how the remplissage procedure has behaved. So Pfizer is nothing but filling index score of remplissage. It is an index to assess post-operatively through MRI how much is the filling or how much is a healing. So good filling is associated with good outcome. So they have categorized into 5 categories. It is very simple, nothing great about it. So grade 4 is the highest. Complete filling is there. Partial filling less than 50% is grade 3. Partial filling with more than 50% is a major defect is there, then it is grade 2. Or minimal fluid, then it is grade 1. And there is filling failure, it is dehiscence. So I'll show the MRI pictures how it looks. So when there is a complete filling both in axial section and the sagittal section, it is 4 and 4. And when and it is grade 4. When there is a partial filling, so we can see that 50% is filled, 50% is not filled in axial section or in the sagittal section, then the point is 3 plus 3. And when there is more than 50% is not filled, then it is grade 2, both in axial and sagittal section. And in grade 1, there is very minimal filling. Only the edges are filled, and a majority is not filled, even in spite of putting the anchors and then tying. Then, or it's a failure of the remplissage. It is 1 plus 1. And of course, there is no filling and there is a dehiscence, or there is completely cut out. When sometimes in the infection, it can happen like this. There is completely cut out of threads, and there is a dehiscence, then it is 0 points. So there's some points on both axial and sagittal section, whether it is excellent, good, fair, or poor, depending on this score. This is the Pfizer. So the controversy is 2 anchors or a single anchor. There is both advantages and disadvantages of using single anchor or 2 anchor. The single anchor, there is less restriction of external rotation, cost effective, but disadvantage is inadequate filling. Whereas multiple anchors, there's a good filling, and but the limitation is the external rotation. So we did a study in our hospital to look into our data of remplissage cases, and we include all the instability cases, and these are our pre-op and post-operative data what we have collected. We had about 30 patients after excluding the loss to follow-up and other patients. So the surgical technique was simpler. We have used in all cases double-loaded anchor, and then the parachute effect kind of remplissage repair was done, and then the Bankart in all the cases, and this is how the remplissage looks. The defect is completely covered, and the results of our studies showed that these are our patients' demographic data, where we had 10 patients from the sports population. We had excellent, significant improvement in the clinical scores, Oxford instability scores and Ravi scores, and there was no redislocation. The external rotation loss was about 4 points. Mean was about 4.6 degree in neutral and 4.2 in the 90 degree of abduction. The Pfizer score showed excellent in 21 of 30 patients. That is 70% showed good filling with both the sagittal and the axial sections. So we had an excellent radiological filling in 70% of cases, no redislocation rate and no external rotation loss. So this is the slide which is compared to other studies. So one anchor itself can give sufficient Pfizer score. Need not go for two anchors, and comparison of redislocation rates. There were no redislocation in our series, and functional results as well as good, and the external rotation also was comparable with the other studies as well. So to conclude, single anchor double loaded with mattress techniques provide excellent filling of the hill sacks. With 70% of our patients, there is no redislocation after surgery. Remplissage procedure with single anchor yields good to excellent clinical outcome, and with less restriction of external rotation. Thank you.
Now I request Dr. Raghavendra to present his talk on open versus arthroscopic labral repair.
Morning, everyone. Thank you, Srini, for the kind invitation. Thank you, IAS. Honor. IAS platform. Hello. I'm surprised. I'm a bit surprised that Dr. Ramakant sir didn't mention a word on open repair in his algorithm. We'll see. You mentioned? Okay, okay, fine. Thank you. So I'm Dr. Raghavendra from Mysore, working in Mysore, and so I'll be talking on open Bankart repairs. we know that Bankart repairs was first described by Dr. Bankart way back in 1928. Ever since then, it has been a revolutionary surgery. A lot of arthroscopy changes have happened, but is open Bankart a really good option even today, or is the open stabilization is only for the Dinosa surgeons, which was published in 2011. So we can see there is a huge paradigm shift from 2002 to 2009. There have been a lot of increase in the number of the arthroscopy cases. And the more number of cases we have done, we have experienced the problems with arthroscopy, the complications rate, and we know that the indications of arthroscopic surgeries are getting fewer in terms of arthroscopic Bankart. So let us have a quick look at the literature. When was the last time the open meniscectomy was described in the literature? It was way back in 1987. So after that, there has been no publication on open meniscectomy. On the other hand, open Bankart and open Bankart versus arthroscopic Bankart. There have been immense literature even today. There have been comparisons. There have been publications on open Bankart, and that shows that it's not open stabilization or open Bankart. Is it obsolete? Absolutely no. It is in fact a gold standard procedure for a lot of indications. So we'll see. Now there have been, as I mentioned before, there have been a lot of publications on open and arthroscopic Bankart repair in the past, but probably this is the one publication which have been which has had a high impact in terms of homogeneity of the publications and in terms of follow-up. So it clearly mentions that it was a 2-year follow-up study and clearly mentions that the recurrence rate in arthroscopic surgeries is almost double than open surgeries. We can see in the statistics, it's almost 23% of recurrence rate after arthroscopic surgery, whereas it's half, only 11% in open stabilization surgeries. And this is another review article which was published in 2020, review of review articles. So he took 6 review articles, and we can see in the picture, in the statistics, the recurrence rate in 5 of the review articles has been quite high, even though not statistically significant. Only one study by Mohattadi et al. In 2005, which shows that it is statistically significant recurrence rate compared to the arthroscopic surgeries. But only one study showed arthroscopy has a better outcome than open surgeries. So what is the general consensus then? General consensus is recurrence rate is higher in arthroscopic surgery than open stabilization surgeries. So we'll see what makes open surgery special, or what are the pearls of open surgeries. So we know it is a Bankart procedure like arthroscopy procedure as well. It's a anatomical procedures, unlike lateral, which is non-anatomical. And the very important aspect of this open surgery is we can easily free the capsule from the subscapularis and prevent the adherence, because we know that capsule has very pivotal role in stabilization. So we can clearly separate the capsule from the underlying subscapularis muscle in open procedures. So the third point is we can have a clear access of anterior inferior labral lesions. So we can see in the pictures, we can see the labrum and the capsule being completely separated from the bone, and we can have a clear visibility, and we can access to whatever extent we can. So, and we can take a good bite, a robust bite from the capsule and the labrum. Unlike arthroscopic surgeries, we can go even till 6:30, 5:30 to whatever extent we can. So we can see, we can take a good bite. We can make a double row as well, single row, double row, whatever we can. Now, as I mentioned before, the capsule is very pivotal role in stabilization. So we can have a very good control of a capsule. So here we can see the horizontal capsulotomy, and we can make an inferior flap and superior flap, and inferior flap being moved out laterally and proximally, and superior flap being moved out distally and laterally. So we can have a double thickness labral double thickness capsular repair along with the labral repair. So inferior pouch closure, that's another very good advantage of open procedures. So when we make a vertical capsulotomy, we can pull the medial flap laterally, and we can pull the lateral flap medially so as to close this inferior pouch. We cannot have that in arthroscopic procedures. So Dr. Ayyappan Nair was mentioning on the rotator importance of the rotator interval in the morning. So yes, we can definitely access the rotator interval better in open procedures, and we can close with a good number of sutures so as to prevent the recurrence. And we can have a good optimal position. The ideal position of the repair would be 45 degree of abduction and 45 degree of external rotation. That's again a very important aspect in closure. And we already have seen that complications rate have been very less compared to the arthroscopic surgeries. Now, again, like any procedures, we can have pitfalls as well. So we will have a larger incision, and subscapularis disruption is very much concern. So we have to see we do not disrupt the subscapularis. We need to have good repair after the surgery. And it's very difficult to have intra-articular access like slap lesions. And there is, of course, potential loss of external rotation. Now, we have seen the pearls and pitfalls. So let us move on to the indications. So the major indication is age. So there have been a lot of papers which says that when we do open repair in age less than 20, the results are far better. And collision athletes. In West, rugby is a major sport. So whenever they have rugby patients, they always do open procedures to prevent the recurrence. The why? Because when we repair bankards in collision athletes, the stress, the amount of pressure which they exert while playing sports on the repair is too much. So that is why they tend to have failures in arthroscopic procedures than open. So again, there are a lot of papers which says that open procedures in collision athletes are better. And subcritical bone loss. So this was my teaching when I was doing my fellowship with Dr. Giovanni Da Giacomo. Subcritical bone loss, we already spoken. So open capsular, open bankards or open capsular shift is a very ideal indication for open procedures. Now multiple dislocation, again a very good indication for open procedures. Multi-directional instabilities. So as I already mentioned, we can have a good control on the capsule. So I have had a few experiences with open procedures. So this is one patient who was a welding operator, and with a multi-directional instability. He was a generalized lax patient. So I did arthroscopic remplissage, and I did an open bankard repair. So this is a 2-year follow-up, and we can see a good rotations, no restricted external rotation, and apprehension is being negative. So revision surgeries, there are a lot of papers which says that open surgery is quite better in revision surgeries. So now not all the patients are same. So we need to have wide array of treatment options. So which can start from rehabilitations So of course, arthroscopy is a very good options for Bankert repair. And whenever you have a bone loss, critical bone loss of more than 20%, lattice is a best options. And in between, there are certain group of patients which I already mentioned. So open repair is a very good option in such patients. Now, we all have been trained in arthroscopic procedures, so I'll not be getting in details with the arthroscopic procedures. Let us have a quick look at the open procedure. The position is beach chair. The classical incision is mid-axillary, deltopectoral plane. We can see the cephalic, and it's always better to put a self-retaining retractors. So now how to handle the subscapularis. So Dr. Matthew Preventure and Antonio Romeo in their textbook, they have classically mentioned this vertical incision 1 centimeter away from the stump in non-overhead athletes. Whereas in overhead athletes, they describe this horizontal opening of the muscle so as to prevent the muscular damages. And capsular handling, so either we can have a horizontal capsulotomy, so that's to have a inferior flap and superior flap. Inferior flap again can be used for the Bankert repair, and we can at the end of the surgery we can move the inferior flap proximally and laterally, and the superior flap distally and laterally, so that we can have a good tight capsular tightness. Now, again in the textbook they have mentioned a lateral-based T capsulotomy, where we can have a pant in vest kind of a capsular closure, which is again very robust kind of a capsular repair. Now, this is the one technique which I want to mention, described by Lafosse, none other than Lafosse double row again. So medial row 1 centimeter from the cartilage, and the lateral row is again just adjacent to the cartilage. So this is the end of the repair. Again, very useful for revision surgeries. So what does the literature say? Now, the great Robert Anserio mentions in his review article, do not forget the open Bankerts, look at the evidence. No surgeries are outdated. As we can see in the picture, this crystal pen, big crystal pen, which was being sold out even now, started from 1924. So no procedure is outdated. Open Bankerts is very viable and very good indication, very good procedure for a lot of indicated patients. Thank you so much.
Thank you, Raghavendra. Srinivas.
Sir, hello. Sir, I request all the faculty of the third session to come onto the stage. And I request Dr. Pathsar sir and Shyam Prasad sir to present the mementos to all the faculties. Sir. I request Ramakant sir to present moment. Yeah. There's a small change in the schedule.
We are running out of time. The live surgery will be relayed first, and after that, we'll have a panel discussion on the instability. So the live surgery is being relayed from Care Hospital, Arilova. I really thank the management and Dr. Sodan and Dr. Kitnagaru for rescheduling all the OT cases for today and providing all the logistics and staff for this live surgery to be properly going on. So a small AV on the our institute.
Srinivas, with your permission, I just want to say a few words. First, I thank Dr. Srinivas for giving me this opportunity to chair this session. One take-home message I would like to give to these youngsters is, see, this arthroscopy is something like swimming. Daily you go to the swimming pool and watch, there's no use. You need to jump into the pool. So similarly, over my life, I have so many names whom must have assisted, right from Simon Prostate, Christina Podes, way back in 89, I was very close to Anand Joshi, used to roam around, do surgeries in all those hospitals. But as long as you keep assisting or you are with the team as a second assistant, it doesn't make a lot of change. The point is you need to jump into the pool. It's only then you'll know what is the problems and all that. So what I advise all youngsters is, in fact, I would have kept one rule. If you have not done the scope, don't enter this room. There's no point. There's no point in going into all these details. They just go up your head. At the most, you'll just meet your friends and have a nice sleep. So the point is you need to have a touch. So you all have to take initiative and do it. That's it. Do it. There's no way to get it out. Until unless you do, and over a period of time, as you keep doing, the experience comes in. See, as you all know, in open surgery, it is said, one case you can assist, one case you see, and the next one you can do. But whereas in arthroscopy, there's a long learning curve. So to get that learning curve, you need to finish climbing the tree as soon as possible in your life. So the more early you climb, the better you can have more time to pick up the fruits. You take a lot of time to climb the tree, then maybe at the end, there will be no fruits left because all the fruits will be plucked by somebody else. So the advice I would like you all is to be doing. In fact, again, I thank Dr. Parsarthi. After I've seen so many Western surgeons, but he is the guy who made me do hundreds of cases and then made me get the experience, of trying to do with even closed eyes, we would sometimes try to do. So that is what I would say. The practical is very, very important. So you are having a lot of opportunity to attend these conferences in Vizag at a very frequent, just about 2-3 months you are having a conference. So you need to go back and start it. I hope there is a small piece of advice I would like to give to you all.
Thank you, sir. So the live surgery one, this is a patient, 24-year-old gentleman. He's a fisherman by occupation. He had 3 episodes of right shoulder dislocation. The index dislocation was in 2022, next in 23, and the last one 1 month back. And his MRI shows a large Bankart in lesion extending from 3 o'clock to 6 o'clock. And his CT shows 2 to 3% of bone loss, which is not, okay. And he's got a humeral Hill-Sachs lesion, and the glenoid track is 20.25 mm, and it's a non-engaging and on-track lesion. So with this, O to OT.
Hi, good morning. This is Dr. Ayappan. Am I audible, Srinivas? Srinivas, am I audible? Audio check.
Yes, you are audible. Just a second, a doctor is connecting.
Yeah, sure. Yeah, we're about to start the case now. I thought we'll discuss. We already put up
Hello?
the. Can you hear
OT?
me? Can you hear me?
No, we are not. We are
Can you hear
not
me?
getting reception. Not audible, not visible. Now visible.
Hey, can you hear me?
Yeah. Are we audible?
Yeah, we can hear you. But
Sir,
we can
yes,
hear
sir.
you.
We can hear you as well, sir.
Very good. Great. So good afternoon to you all. So we'll start with the first live surgery now. The plan is a Bankart with remplissage with RI closure is the plan. And all of you have already listened to the PowerPoint and the history of this particular patient. So now you can see that it's most recent is like a month back. So this is the MRI, the axial views. So we can see the AC joint and slowly down inferiorly coming to the coracoid. You can see the supraspinatus here. Then gradually when you come down, supra disappearing. And here you can see the subscap. And you can see there is quite a bit fluid in the near the rotator interval. And then you come down, you can also see the hill sash being formed. That is posterior superior, the hill sash. It is very well defined hill sash. Yeah. Yeah. So you can see the hill sash, and then you can see. So I think morning Shivanand sir was mentioning about the labrum, how triangular the labrum is. You can see it is disrupted here. And again, you can see the disruption. You can't see the triangle at all. The capsule is also disrupted here. So we can see if it is a coracoid, and below the coracoid should be the 3 o'clock position. And then you come down again, and down again, you can see the posterior labrum. You can see the disruptions here. Then you can see the rounding of this glenoid. That means it's a erosion type Bankart. So then that is most inferior, must be around like 5 o'clock-ish where this area is, and then down. So let's go to the SAG images now. You can see there is deltoid, the head being formed, and then gradually you can see this is the hill sash in this area, and you can see the separation here. This is the coracoid. You can see the glenoid. You can see the disruptions in this area. It's going down like that. And you can see here. So this is the conjoint tendon coracoid process. Subscap is intact, but a lot of fluid is just coming around that. And then you come down again. The rotator cuff. You can see the supraspinatus. So you can see the recess is filled with fluid, and then down again. So it doesn't look like any other muscle tears. So this is the MRI. So now we'll go in. Go slow because we have 1.5 hours. We'll try to go slow, elaborate on this case. Yeah, am I visible? Nice. Okay.
Hello?
Can I have a small? Okay, fine. Am I visible? Audible?
Yes, sir. Yes. Yeah.
Am I visible and audible? There's no response from the audience. Is there somebody moderating?
Yes. Sir, I would
Can
like
ask
to
somebody to moderate,
invite
Ramakant or somebody to moderate, so that I can start
and
talking
Dr.
to somebody.
Seshibhushan, sir, to come onto the dais to moderate the live surgery, and also Dr. Naveen Pala, sir.
Right. So you can see the position now. The patient is in lateral position. All my bank cards and most of my work, rotator cuff, bank card, everything is in lateral. The lateral, Dr. Sridhar was mentioning about the lateral advantages, disadvantages. So here, I don't have much of traction. It's around 45 degrees and slightly forward. This is good enough. And if required, we can just lift it up. That's enough for me. And this way you can replicate it anywhere. So go to any small center, anywhere, you can just tie it up like this. It's not very difficult. And see, this is a marking. You can see the clavicle, the AC joint here. Is it visible? Yeah. And this is the acromion. There's a coracoid process, CA ligament, and then you can see the acromion coming back. And there's a 5 centimeter mark for the axillary nerve. And my regular port is going to be a posterior port. I don't know if we can see from there. The port is gonna, it's basically for me. So I don't go like 2 centimeters down and medial. It's just in line. This is good enough for me. And my antero-inferior would be just here. That I'll visualize and then put it. So I go in with a skin incision. Madam, starting. And so then what I do is I take the uh, I take my artery, but I don't split it. I'm basically feeling the glenoid, feel it, and then, but I don't penetrate the
not visible.
capsule. So that's because I don't want too many rents in the capsule. Assisting me is Dr. Srijit. Srijit is an associate consultant at Manipal Hospitals working with me, and Praveen from Ceronics, and our staff, sister, your name? And yours, ma'am? Yeah, Sai sister, and your name? Bharti from Care Hospitals.
Evan, Ramakant here.
Hi,
So
Rama.
for the beginners, could you tell how you enter the joint? What is
Yeah,
the
that's what I'm trying to tell
direction?
now. So what I do is, basically what I did was, yeah, there are
How you
different
know
ways
that
of entering the
inside
joint.
the joint?
Let me see if I'm inside. Yeah, the different ways of entering the joint. So one is, my skin marking is just from my
Skin
acromion
is not
marking.
visible
I'll just make a
on the
skin
OT.
incision. That's all. And after that, I take an artery forceps and I feel it along the glenoid, posterior glenoid, till I come into the space between the glenoid and the head. You can feel a triangular space there. So
Soft spot.
yeah, it's a soft spot there. And then once I give the feel the soft spot, 1 second. Pump is not working. I'll just come back to you, Rama.
Yeah, sure. Take your time,
Get this
because
sorted
whenever
and
we enter, this is what we want to know. This is a common scenario when we try to enter. There will be a lot of bleeding. We just need to have some patience, and when the pump is good, and hypotensive anesthesia is there to help from the anesthetic side, we'll have a good vision. But of course, this bleeding will settle in probably another 5 minutes.
Okay.
Yeah, that's good view there. That BP is around 88/53. We just saw that.
Right. So what pump are we using? Artex pump, increase pump pressure to 45. Increase to 45. Right. So that's what I did. Okay. So I basically I took the mosquito and I was feeling along the glenoid till I came to a soft spot, but I didn't penetrate it. So the other way for somebody to start doing it is feel with a spinal needle and then feel it where the soft spot is. Then you make an incision in that. Then what I did was once I removed my artery and took my trocar cannula and started feeling along the glenoid, and then it
Yes.
came up to the same soft spot. Then you have to keep your finger here. What I did was I kept my finger on the coracoid here and directed the trocar in line with that. So you can feel that giving away. The thing is, in younger patients, the capsule is going to be slightly more elastic. So you find slightly difficulty in penetrating it. That is a possibility. So here, and once I'm in, this is a trick to, so if you do this 2, 3 times, you can see that the water clears out and the visualization is much better.
Better.
So that's, so basically I'm in the rotator interval, that's a subscapularis going up, and then this you can see the glenoid, and this is our biceps.
Lighthouse of the shoulder joint.
Right. So what I will do right now is, I'm planning to put my anterior port. I'll show you the rest of the diagnostic little later. So this is how I put this. See this, this is my anterior port. Where do I want and how do I want it? So you can see this is the subscap. It should not be here. I should not enter at this part. Why? Because when my cannula comes on, it will, the subscap is gonna kind of tend it and will not allow my mobility. So then what else? So here what I have to do is so you can see the glenoid.
You have a good space to work.
This is like the 5, 6 o'clock position. I would like my spine needle coming here because this is where my anchor, when anchor insertion is going to be in this direction. This should be comfortable enough. That will happen only if this is at the apex of this triangle. You can see this triangle and this at the apex of the rotator interval. Here.
So that's an important trick. Before putting the portals, we can just maneuver the needle and then see where all we can reach. So we have to reach that 6 o'clock position. So that tells that we'll be able to reach with the
Then,
cannula as well.
Yeah. Now you can see the next step which I've taken the artery. I'm taking a mosquito and moving it in 2 directions, opening up like this as well as in this direction and then pulling it out.
Horizontal and
So this will
vertical.
be followed by my Visinger rod. Especially in a Bankart, I would like to have all my cannulas in place quickly as possible. Here, the first dilator, small dilator is coming in. This is possibly a 6 mm dilator, and then on top of the Visinger rod is 4 millimeters, and then coming in 8-1. Yeah.
The dilators just to expand the track so that the cannula stays in the
Okay,
position.
Stand by. Wait a minute. I'm telling you. What? Wait a minute. Visinger rod thallu. Right. Now push.
That was our second portal.
Going already. Right. Go. Yeah. Yeah. Out. Right. Just basically, I want 2 threads of the cannula in. So now you're safe. Okay. So once this is done, then you can play around how much ever you want. So what I would suggest for everybody is like once you're inside, so once you start playing around, see, you start doing the diagnostic. You have a tendency to keep coming back posteriorly. You can come out of the joint. Then again, you get stuck. So coming out of the joint and getting back into the joint is one of the most dreadful things as a beginner. So it will take you another 15-20 minutes. Sometimes you get frustrated. So that's why I said, okay, put up a cannula. And then you can see here, I'm coming into the inferior recess. That is the humeral attachment of the inferior glenohumeral. And you can see how the labrum is separated. The IGHL is separated. You can see there is no labral attachment here at all.
Yeah.
It is like an Alps. It is going all the way down.
All the way
The
down. So
periosteum itself has gone out. And there's some
that
bleeding
will-
here.
Yeah.
There's some bleeding here into the inferior recess. And that's why it was troubling us with the visualization because the hematoma was there. And then I see the biceps and then I look at the rotator cuff. So here you can see it's all in a plane with your light source. So don't have to move the scope too much. It's all in the light source. So you can see how I'm adjusting the camera, and then you can see how I'm going along the cuff. There's a rotator cuff supraspinatus. So another trick is if you don't want to go out of the joint, keep a finger at your posterior port in the skin, and then slowly adjust. So you can see the hill sash coming into the visualization. You can see the hill sash. It's, yeah, there's a pretty big hill sash. Right. RF is it? So RF foot hand. Foot switch. Oh, Okay, now we'll withdraw it slightly. Yeah, there is some villi here. I would like to burn it off. I would like my anatomy very clearly defined. And here, without affecting the biceps, I would like to do that. So,
yeah, otherwise it will come in our view.
yes, yes, yes. So, I would like to, and that is done. So now, pro, please. So we have seen the labrum. You can see that inferior labrum is wholly from this position. 6 o'clock, it is attached. And then I'm continuing with the superior labrum. It looks okay, but I'm going to probe it and see. You can see it's nicely attached.
There's no slap.
There's no slap there. So then I'm going to withdraw the cannula slightly, and then I'm going to pass this under the biceps and then pull it. So pretty good. So why? Because now you can see, you should see the bicep sling. The biceps, especially if there is a subscap tear, the biceps will come out of its sling. You can see it is nice attached. It's good.
Yeah.
There's only features of this in this particular joint is of recent dislocation and trauma, because you can see it is, you can see all the villus and the capsule is kind of edematous and slightly inflamed. So little high chances of this patient developing postoperative stiffness is there. Some bone piece is running around there. I think we'll come back to it later. Okay, so that being done, spinal. I'll go with my transcup port. So here you can see how I showed in the picture earlier. So where I want it. So you can see that this is how I go about it. I want my visualization here. That is on this side of the biceps. Some surgeons would do it here. They would go a little more here.
Can go.
Yeah, some surgeons would do it here. So I would like to do it a little more this side. Why? Because that gives me better visualization. And we have published this paper in JSES around 5 years back on the outcomes of transcuff port. So this is where I would like to go in on top of the biceps. My cannula is in position right. Right. Knife. Right. Knife in, please. So knife out. You can see I am putting it. This port is basically on the acromion. It's on the anterolateral of the acromion. So next, I would like
edge
to.
of the bone.
Right. Right. That's my knife going in. And I would like to come in through that spot. So right. And my first small dilator comes in. Go, go, go. Because especially if the tissue, enough. Yes,
Just
enough.
expand the.
Yeah, it just expands it, because sometimes I don't have to, but in some cases I have to, because especially in younger patient, what happens, the capsule will be very thick. You try to penetrate with your scope, trocar doesn't go in.
Yeah, and the scope comes out and it becomes very difficult.
So I'm changing my position now. So I'm coming to my visualization port as this one now. Right, I'm inside. And then here I go.
The scope is being switched to the anterosuperior port now.
Right. Now you can see everything properly from here. You can see the bird's eye view. It's beautiful. You can see how the head is subluxed out. You can see that. You can see how your hill sash is. So see the kind of hill sash we have, and see the okay. Grasper, please. Grasper. So I can see a loose body there. Oh yeah. One minute. Right. So the trick in catching the loose body is that sometimes you have to stop the flow. I've stopped the flow in between, and there is some fogging which is happening now. Can you just clear it up, wipe it up for me? You stop the flow. once you stop the flow, and then you, if you want, you can open your portal side valve. Close the side valve, please. Right. Nice. That's good. Okay, let's start with our remplissage, Hilsage. So, so you need not, you saw the posterior port. I need not go through the posterior port. I will use the posterior port if that is coming in my view. I mean, it should be directly on top of my Hilsage. Let's see what I'm getting. See, it's good enough for me. I think it's okay. I might change it.
So what is your plan for Hillsacks now?
One triple loaded anchor should be good enough.
Okay.
Let me clear it up and see. So right now, one triple loader looks fine enough for me. Right. So maybe anchor will go in this spot, in the middle. This.
Okay. So where exactly you would like to place the anchor in the Hillsacks? As we can
So it
see,
depends upon how it's normally here. If it is a huge Hillsage, one anchor here and one anchor here. That's my normally my pattern. So,
okay. So
but
for
I
bigger
can change
Hillsacks,
it.
you use 2 anchors.
Sometimes I use 3.
Oh, okay.
Knife. I use 3. Basically, the idea is to span it out.
Yeah, so that the entire coverage is there.
Yeah. So here next step, okay, see, I go with my Visinger rod. You can see it is coming this direction. Then I go to the side so that the Visinger rod does not penetrate into anything else. And then I ask for my dilation, the second dilator. So you can go directly with a 8 mm dilator, and I'm going to put in a smooth cannula. Go, 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 go. Right. Go, go, go. What? Right, enough.
You are using the same posterior portal, or you
No,
have
it's a different port. It's a posterolateral port, or a posterior superior one. You can see my viewing port is a little more down here. So I was not getting the correct axis. So I want the absolute correct axis. So I changed the port into posterior superior. You can see the posterior superior at my, which is at the angle of acromion posteriorly.
Okay. So the same one you will be using it for taking the 6 o'clock bite, or?
It depends on what is coming into my skin. Okay, skin. I don't know. Right, wait. Rotate ಮಾಡ್ತೊಂಡಿ. Okay, right. You can see this cannula coming in. This cannula is exactly in spot RF. That's it.
Perpendicular axis for your anchor.
Yeah, so you can see how my cannula isn't bang on my Hillsage. This is something which I like. And so then because see, there is always some amount of, some tissue will be normally here. Some fibrous tissue is normally on this area. And even if you start burring, the tissue does not go away. So I would like to burn with my RF little, and so till that tissue goes away, and then I will come with my burr. Right.
Yeah, that's a very important surgical tip there, because we need absolute good preparation of Hillsacks, because once we fill the infraspinatus into that, there has to be a good healing, isn't it?
It has to heal up, absolutely, Raman. So it has to heal up perfectly. So just putting the anchor is not good enough. Okay, you can see that. So now, normally some amount of subfibrous tissue. You can see this tissue here. This kind of tissue will be sitting on top of this, which does not allow healing to happen. Hold the cannula. Yeah. Bar, please. Anchor ready. In the front. Triple load. This one. I don't know. So I go with my preparation. You can see.
Burring is also important just to get a small bleeders out.
So because the cortex, the kind of the bone would be pretty hard there, it does allow healing to happen. So
Yeah,
this
just
has
to
to become
remove
like
that
bleeding cancellous
sclerotic.
bone. So sometimes I might do little microfracturing there, but it can cause little bleeding, so I don't like it much. Yeah, cannula in. So Dr. Srijit is holding the cannula. Then okay, here you can see the next step. So where we are making a small drill. The anchors depend upon the kind of anchors you use. So here we are using a Ceronics triple loaded all switcher. Go. And then each anchor has its, so you can either tap it in directly, there are different ways of doing it. Not required, right? Right. Mallet. Counter. Counter, counter. So
What is
giving
the
a little
size of
counter
the
there.
anchor?
So the triple load goes in. Yeah, done.
What is the size of the anchor?
It's a triple loaded 2.9 triple loaded all suture
All
Xeronics.
suture.
Yeah. Out. Right. Now, next step, what we do here, I have to pull this cannula out. So there are different ways of doing the reblissage. So sometimes what I do is, when I have time, okay, I pass all the sutures, then cast them subacromially, tie them subacromially under vision. Here, especially for when you are starting off, you don't want to complicate your surgeries. Keep it as simple as possible. So this is the simplest way to do it. So you have to slide this out slightly. You can see out of the tendon and out of the capsule. You can see it. You have to slide it. You can see it. You can see it being slid nicely there. Yeah. And now bird beak. So now I like to use a straight bird beak. Candle hold, please. And I would like to span my attachment. So you can see that my first is going like this. One white is coming out. And Dr. Srijit is helping me with the shuttling. You can see how he's candle one hold candle previn. Yeah. You can see it's not getting unloaded. So this is the suture which I passed. I put an artery in it, marked it up. So now I'm going with the next one.
So to avoid unloading, so can you show the second bite?
Yeah, I will show you. I'll show how to prevent this unloading. Can you just pull? Okay,
that is a very important step because most of the beginners would unload the anchor.
Yeah,
So,
okay. So here what I'm doing is, so I'm catching this. Yeah, see, I've caught it, and now you can see what's the step. So I'm holding it. So now we'll show how Dr. Srijit is pulling it. You can see how he's pulling this thread. So when you're pulling the one end of the thread, it should not come out of the anchor. It should not slide here. So that means if it starts sliding here, means it is getting unloaded.
yeah, there should not be no anchor thread
At the
movement in
anchor
the
side,
anchor.
there should not be any movement. All your movement should happen elsewhere.
Yeah, that is a very important step. That is a very important step what he is showing, because once you catch hold of that and then pull it, there should not be any movement in the anchor. So that assures that the anchor can never get unloaded.
So again, the same steps being repeated. You can see that Dr. Srijit is pulling and the anchor is not moving at all.
Yeah.
And whichever we are passing, we are putting arteries in it so that we know which we are passed and there's no confusion. And otherwise, you lose count of which one you are passed, which one you're not passed. So then one, right. See, now it's coming off quite easily. And then see how I'm passing it. I'm passing it from that side and this side, different directions, up, down is my pattern. So that way I get a good spanning effect on my
spanning effect and what they call as a parachute configuration.
Yes. Here we can see again.
Fancy names.
Passive. Right. Okay, my last thread is coming in now. So, right, all passed, done. So now, artery release, artery on. So I've released that. I removed the cannula now. So I can now focus on the remaining. I think I need to remove some of this meniscal punch. Some cartilage is loose there. It's going to be a loose body in some time. So I'd like to take it off. Right. Right. I'll shave it off from down later. That's fine. Okay, so now you can see the lift here. You can see the labrum now. You can see how the labrum is intact or totally at that particular spot. It's around, 6 o'clock position. Beyond that, the labrum is deficient. So here, I would like to start elevating here. So here, this is what I would do.
So all,
That was
all the bites are taken and then you would tighten it after your Bankard's
yes,
repair.
yes, absolutely. So I'll do it entirely after this. Sister, sister, come. Ah, just push. Come, come. Push, push, push. Ah, correct. So here, elevator. So I'm using the same port of my Remplissage because it's a very high port. You can that gives me an excellent access to this labrum. So I would like to elevate the labrum here.
7 to 6 o'clock.
Yeah. So I would stop because yeah, hit. Go, go, go. Bono. Where area, okay. Ready? Correct. Correct. You can see that is the labrum. If you try to identify the labrum anteriorly, you may not be able to get it. The trick is to identify the labrum here. So what I've done is, see, I have identified the labrum at this spot. And then I will continue with the labrum that anteriorly. Right. Thank you.
That's around 6 o'clock position. You're just moving around to 5.
6:30, rather, I come to around 6:37. I will come.
37.
I have elevated it. So lift, Praveen lift. Right. You can see now. Yeah.
So that's a very good trick actually to access the labrum from
Labrum, because otherwise you try to identify anteriorly, you will never get it sometimes.
Yeah,
So
it will
this
be way
way you
below.
can access it like this. Right, elevate. Right. Right. Okay, ring curate. RF code first. RF code. Right. So next, I would like to prepare. Right. Yes. Now I would like to prepare this here now. So here you can see I have elevated the labrum, but see I need to prepare the bone. That's what I was trying to tell earlier when I was giving that talk, that we need to prepare this bone
want to give
bone
2
bed.
mm of the
So I
edge.
am removing the bone bed here because only then this is going to heal back properly. And that way you can identify your anterior edge of it. See, this is your bone bed. This way you can identify the bone bed nicely. Here. Right. And I will continue this anterior preparation later. So I'll just finish off this position now. Curate. I will take a curate now. And I would like to take off some bone here. Like this. Not too much, only very less. So this, you can see this bone bed here. So that bone bed has to be visualized and well good. So now that gives me enough space to start. And then I will definitely continue this anteriorly. So here, I'm gonna. Right.
So
So
you're doing this from the superior, posterior superior portal.
absolutely, posterior superior. So there's no strict rule like you have to do something on a particular port only. So I can
The
use it from
access.
the posterior viewing port or the posterior superior port. Here, the posterior superior gives me excellent access to that area. Elevator once more. Single loaded, all switcher. I would like to make the final preparation now. Okay, before I go anterior here. Ready, good. Edge. All right, ready, good. Right, element. Right. Right. Ready, good. Right. Right. So my bite is going to be here, and I'm going to placate it here. So that's
Yeah.
later. So now I will finish the anterior. So now you can see my light source position now. How my light source is, and you can see. So if you have to be careful when you can always keep a hand here at the skin side, at the portal side, and you can see now. Your one thing normally people miss out is this particular cannula keeps going out. So you have to keep pushing it once in a while. So now you can see the anterior to the RF. So here now we'll start anterior preparation. Just pull sister. Very good. So you can see that okay, here I start the anterior again, and I'll show you like how we can slowly elevate the capsule. So, but you start with the cartilage edge. You can go a little more closer. Let me focus a little more. Right. Yeah. So here, what we do is go like this. You can see the continuity of the inferior. See, I've gone till there. So now I need to continue this way as well. So I'm coming up till this 3 o'clock position like this. Like this. Yeah. So now the next step is I would like to elevate it from the side. So here I have to visualize a little more better. See, I'm actually got my light source. Light source is, look at the position of it is. So it is actually allowing me to visualize the side. Can you see that? So how it is going down like that? Yeah. So it goes like that. So then same thing again, you go down, 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 down. Yeah. And then here again, you can see down, 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 down. So here again, you can see that IGHL complex. So you need to go along the glenoid, down, down, down. Correct.
So you always use RF for elevating that, or
Sometimes, okay, sometimes, okay, it depends upon, especially in a periosteal sleeve avulsions and all, I like the RF. So I use a combination. So now I'm taking this elevator, and elevator is coming in. You can see, I would like to have the continuity here. So we'll start again. Okay, go, 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 go. Right. Go.
that is a very important thing, how to use the RF.
See.
So RF was always facing the glenoid, isn't it? Because when you face it anterior, you can damage the labrum.
So here, what I've done is, okay, here the elevation is okay, but I need to go more down and elevate. So here, so you continue like this. Let's see. Okay, wait a minute. Right. Go, go, go. Go, go, go. Go, 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 go. Right. You can see it is how that it is elevated. So I need to go a little more. Oh, wait a minute. So sometimes malleting is also not required. You can just keep pushing it. It will go. You have only one angle. Praveen, one more elevator is there, different angle. Right. So they have two angles of it, but so that, yeah, like this. Yeah, there you go. So most of it, you feel that, when you look at a particular case, when you start a particular case, you definitely feel that sometimes, yeah, this is not repairable and I might not be able to repair it back. So you can, my take is that you can repair most of it. So the only thing is, you need to elevate it very, very meticulously, like this, elevate it nicely and up. You can see it should come like that. Up, up, up. You can see it should, you can see the subscap under. So this much of elevation you should do. Only then this will come up. Yeah, so that's there it is. I think it is good enough for me to start my work now. Right, we leave it there. Give me a scorpion. So here, next step is I'm going to use a scorpion. Basically just trying to do a blind bite and see if it is going to mobilize. It's enough of mobilization or not. So I go with this like this. Not enough. It's a good bite. I'll leave it there. So
This
that's
is
enough
the
preparation for
Bankat
me.
scorpion.
Sorry.
The Bankat scorpion, is there any difference?
No. I'm
Bankat
using a regular scorpion, a cuff scorpion.
Regular scorpion,
Leaf
okay.
cyst. So here, a single load wire. So here, so first anchor is going to be a now a single loaded.
So you are inserting from the Rampisage portal.
The Rampisage port. I'm just seeing which is giving me better access. I'll go with that. Yeah. See, this is giving me a good access. Okay, take it off, please. So again, the thing is, we always don't have to think that. Article. So we don't have to think that our only anterior ports can be used for anchor placement. Okay, go. Careful, don't push. Take. So here, I'm using a single loaded wire now. 25-degree left curve lasso.
This is the same anchor, all suture 2.9.
All suture, what's the size? 1.5. 1.5, all suture, single loaded. Careful, don't move my hand. Right. Pull. Right. Suture trigger. Thank you. Hold like this, Brian. Okay. Lasso. Out. Lasso. So now once I passed it, okay, I'm gonna catch up with my lasso, which is gonna be a left curve lasso, again coming from the posterior port, the 25-degree. 25-degree. I'm using a 25-degree because I feel 25 is good enough for me to pass from there to in here. Yeah. So here I am using a different port, my viewing port, which was there earlier. So you don't need too big a bite. This is your basically for the inferior capsule application. So I'm gonna start it here now. This at 6:30, and then dig it in, and then
So your lasso is a site specific, isn't it? So you are using the same side or
I'm
opposite?
using a left curve.
Yeah. So you're operating on right side, and then you're using your left lasso.
So we kept all the lassos. We kept all the lassos ready. Now here I use a left curve, and now when I start working from anterior, I'll be using a right curve. So,
Yeah, so
again
that
here
is very important trick there.
pull. Really. Right. Switch it over, please. Right.
So when you're coming from posterior, you have to use the opposite side lasso. So that gives the good access.
ಸುಮ್ಮನೆ ಬಿಡಿ leave some. So now I'm gonna park this. I'm not gonna tie it up now. Why? Because I'll tell you in a moment. So here I parked all the sutures. Now kept it anteriorly. Now I'm gonna take it and keep it. So cannula, adjust please. Right. I will not tie it up. If I tie it, my space is gonna reduce there. I will tie it after doing my 5 o'clock. Double loaded, tape. Okay, curate please.
Yeah, that is a very important thing what he told. So you can take the bites and keep it, park it posteriorly, and then take the 5 o'clock bites.
Lift head.
Close
Lift
the
head.
posterior one.
Sister, thank you. Very good. Beautiful. So fogging, mop please. ചുറ്റിന് ഇവിടെ ചുറ്റിന് right. Good. Right. Shaver please. Switch to shaver. Normally, whenever we are doing a live surgery, we are always on the run. That means 30 minutes we need to finish it off. Here, Srinivas has said 1.5 hours. So, but so we're going extra slow today.
You
Shiva,
are quite fast.
still. Yeah, so I would like to clean it up slightly and then keep it slightly fresh before we go. And there we go. Remove all that debris. Now we are ready for a 5 o'clock. Okay, come on. So here again, you can see I'm planning to put a tape anchor. Take the inner rod and see the position. So I was explaining when I was giving the talk that I would like to keep it in such a place that there should be traction and you should be able to pull this up. So here, pull this means I would like to have it this part. So you can see that 6 o'clock is somewhere like here would be great. There's no point in putting more. Okay, direct drill. No, direct drill. Slow and steady. You're saying double loaded, all switcher tape out.
So what is your preference? You always use all suture or peak anchors?
No, because all these solid anchors can irritate sometime. And I feel the bigger the foreign body there, more chance of infection as well, even though it's not proved that peak anchors will cause it. So I always use all switcher, is my preference. Sometimes when I want to do a mattress, then I will use a knotless in addition. But otherwise, this is good enough for me. So now, yeah, cannula, orange. Orange cannula. Oh, no, artery. Okay, no, knife on. Right, okay, enough. Hold out. So this is my posterior cannula, which I'm keeping it in place here like this. This is basically for my suture shuttling. Sister, always hold this. Okay, keep it here, cannula. Keep a hand there. Right. So when this is done, now here we go. Bucket threads and all. Right. I would like to keep the remaining away when I'm working on it. I would like to have a clear space. Wait a minute. And a scorpion freehand. Okay. So it will study. So I would like to check my reduction of my this thing once more. Of my capsule once more, because I need to get a. Say I need to go under that.
So you always use scorpion for the bites, or you use
Depends upon if I am not able to get a good bite with a scorpion, then I will change. It's not like I'm particular about scorpion. So basically, the bite has to be good and nice. That's all.
Yeah,
and I need a nice proper deep bite. So here looks okay. I think I'll go with this first bite like this. Then if I want, I'll keep changing it.
Okay. Sometimes the scorpion is too bulky to handle.
I tend to disagree, because actually it's around 1.75 centimeters of tissue bite, and we feel it is bulky, but actually it is not. It's because I'll tell you why. Because you can't use with the, for example, first pass you can't do. If here it exactly passes through your cannula, and you should be able to do it without. I don't find it too bulky at all. I'm able to do it quite well. Elevator kodukana.
So the anterior cannula is 6 mm or 8 mm?
Sorry, anterior 8 mm cannula. ಚಿಕ್ಕದಿದೆ ಅನ್ನೋದೇ. Hold here. When I tell you, okay, scorpion load.
Yeah, what he's showing is very important. So he's trying to lift the labrum and the capsule from the posterior so that he can have a nice bite. So that's the important trick there.
Right, because I felt that okay, when I was going with the scorpion, I felt that I'm not able to go under the tissue. Now you take it off. Right. So now
Yeah, that's
see
a
bust.
beautiful trick to get the things in first attempt and to place to get the proper bites.
So switch it over.
So you're
Now
pulling
I'll
it
go for
just
the.
shift the labrum onto the glenoid there.
Yeah, that is the advantage of this scorpion thingy, retrograde passage. So that's the advantage. Yeah, there we go. So once the other one passes, so the well, should we go?
Yeah, it's nicely shifting superior now. What was lying inferior?
Vitamin. Right. Grasper. Grasper. Right. Wait a minute. Switch it over. Switch it over. Right.
Very frequently this looping happens. Then
well, pull both. Right. Right. Okay, done. So that is done with my mattress. Artery on this, please. And now lasso. Okay. 25 degree ಕೊಡಿ. Right. ಇಲ್ಲ ಇದು right left curve. Sorry, right curve back. You can see the capsule coming on. So now the thing is on the molecule. Just pull that. Yeah. So I want a bite from here going in and in. Right. Switch it here. So
this is going to
sister
be
is
your
meticulously
vertical
holding
matter.
the cannula. So here I've passed the. Here I'm gonna have a single pass. I'm gonna shuttle it.
Single
So I've
pass,
used
that's
my
right.
lasso. I've taken the next bite because my scorpion work is over. I can't use a scorpion for a side bite. So from a depth bite, I can take it. So here, when this is done, 1 second, I'll just take this. Come on. Yeah. Praveen, either do. Make it the bidi. Yeah. So what I did right now was I took that lasso loop and one of the threads tapes together. Short, Madi. Yeah. Keep it short. Those. Right. Well, rotate it. Rotate. Rotate. Vali. Right. Right. You can see the next one coming. So that should be good enough. And next, switch it over. Next, I'll just capture it and keep it here and I finished my mattress switcher. So now I'm good enough to go ahead with my mattress switcher. Okay. Leave, sister. Leave. Okay. Now, sister, no. Leave this. Leave this. I'll show you how. Rotate like this. Rotate like this. No, don't lift. Rotate and pull back. See, this is the reduction technique. So you don't. What important thing which you should know is that leave, sister. Leave. See, it is unreduced. Just look at it. So what do we do now? Watch. Internal rotate and pull back.
Pull back.
Hold this position and don't lift. Just pull back. This position, because we want the IGHL to tighten in the tightest position, not in the loosest position. So that's why now what I've done is when I'm going to suture it up, now the IGHL is tight, taut, head is reduced. If you don't do this, what will happen is it will be in a loose position and it's going to head is still going to sublux. Not push it. This is a mattress, so I can use just any of the posts. Thanks. So basically you tighten up. See the IGHL tightening up. Right. So
Yes.
this kind of plication, this is the capsular shift you want. Just a labral repair will not suffice. And one more. So I am going there, pass pointing. Pass pointing. One more switch, and after that, right. Sister is maintaining that internal rotation and a posterior push. So basically, she is pushing it, reducing it back. So this step is important. Here, and then one more. Right. You cut my beda artery. Switch it here. Right. Now I'll take these two, and now that will make the bumper. That means we always bothered about the bumper effect. So now one is mattress is basically pulling it up, and this one will create your bumper by going around as a simple suture pattern. So see for the post is always on the soft tissue side. See that's where it comes. Okay.
So you have to take care that knot has to come on the capsular side and not on the glenoid side.
Correct.
So that's what Dr. Ayyappan mentioned. The post should be on the capsular side.
So here, so again, you go in. Pull.
What type of sliding knot is this?
I'm not sliding because it's a tape. I don't slide. Tape doesn't slide.
Simple one. Okay.
It is basically a simple pattern which I've used because tape will not slide.
Yeah.
This one, no? Right. I would have loved to do a mattress on, a double row on this if I had a knotless. So I think as and when Ceronics develops knotless, we'll put that. So there we go. I finished it. Now, just leave. Leave. Now. Yeah, now head is centered.
So for the knotless double row, you take
I would have done
all
a
the
double
4
row.
threads?
I would have done a double row if knotless was available. Water change. Saline bottle change. Saline change.
No, all the 4 threads you would use it for the double row or just...
No, I would take all these 4 threads together. Then I would have done, instead of passing the one simple, what I've done is I would have done mattress in everything. And then I would have done a double row. So you can see the capsular application, and you can see how it is tied up like this. That's good enough for me. Now, what I would do is, I would finish off this. Pretty good. Okay, we'll cut off this, please. We'll cut it. I'll cut off these threads because I kept it in just in case, okay, if I wanted anything additional. I'm showing you the distraction and the reduction now because I'm external rotating the hand with force. Head is centered. See, it is center. Yeah. Next. Done? Right. Okay. So here, now if you want, you can actually put this, or I can wait also. Okay, give me a double loaded wire anchor, please. So I need to placate at this position. Now you can see the inferior one. I'll put next anchor here, maybe around 5 to 7 millimeters away. At this particular spot, I would do it. I'll placate these tissues. In and out. 1 second. No, right, go. Mandapaka. Go. Out.
This position of anchor is at 4 o'clock or 3 o'clock?
No, the first one is around 5. I think maybe this 4, correct.
4, okay.
I think this is enough. Basically, 3 angles coming up. Also, I'll just see how the reduction is coming. Any more tissue is there. I think I have come almost near the subscap with the plication up. The thread. Okay. Okay. Switch it to it. One second. Same. One. Okay. Hold this away. Hold this away. Yeah. So let's see how where I should take the next bite. So I'll take again. I would like to go inferior. Hit them more down. Tissue, better tissue. Come on, yeah. That should be okay. Switch it over. Cannula hold sister. You just hold it. Now the sister does not have to. She does not have to reduce anything. The head is free, so I can easily, aram se do whatever I want to. Hold this. So, yep. Praveen is loading up, and then coming out. Pull. Vanilla. Right. One more pass. All right. I'll take a little more deeper bite. Cannula. No, Valisana. I got it. Yeah. Pull. All right. Go. Coming out. Pull out. Next. One more pass.
Even for this mattress and single bite you're going to take?
Yes, same one I finished with the black tiger. I've taken the white tiger. I've basically taken the mattress pattern. So I'll take a simple pattern with the pure blacks. So basically, the one is going to do the mat pull effect, and the other one is going to basically give you the bumper. Basically, it holds it down. It holds the tissues in coverage.
Yeah, the simple one will give the bumper effect.
Correct. Right. Now I'll take this one black out, finish the matters, and then come back. So
you park the simple one.
Correct. I parked it away, sister. Same.
Park it away
Do
and
this
then finish the mattress.
like this. Hold. Very good. Just pull back. Correct.
So when we are using double loaded, this suture management is very important. Otherwise, all the sutures can get entangled and then it can delay the surgery.
Right. So then, see the capsule coming up with the mattress. Sister still holding the reduction. I made her do the reduction now, so that whatever extra application I want, okay, is going to happen now. Switch. Switch it to a stand. Better. All right. Audible. Right. You can see the entire capsule come up. Sush. Cutter. Note withdraw. Cut. Right. Right. Scope. Scope. Not push. Put. Right. You can see now that's what I was trying to do. Basically, one is bringing it up, and the other one is basically holding it nicely. Correct. Switch it over. Right. Leave system. The head is now even more perfectly centered. You can see center of the head, center. This view also you can see only because it's an anterosuperior port. So Dr. Srijit is completing the knots off. Yeah, tighter. One more. Right. Enough. Cut. Yeah, that should be good enough. Okay, so you can see that withdraw slightly. Cut. All right. That is the upper border of the subscap. So I'm almost there. So that should be okay enough for me. So if I want, I will switch. Okay, I will check again from the posterior. If required, I'll put it later. So I'll finish off this one now. Hold sister. Cannula. So here I'm planning to finish the inferior one. Inferior, how am I finishing? So here you can see Matale. Right. So this is the post. So first, I'll do a sliding because I passed through the same soft tissue window. If you remember, Ate. So I passed it
You check the
anterior,
track.
then I passed it through the same soft tissue window posteriorly. So I can do a sliding. You can see the sliding. My sliding is not, I don't do any complicated sliding. This was how I was trained. Basically 2 half hitches, you can see that, and then pull along. Right. But here, the trick is, no, don't lift. Pull forward. Push it forward. Correct. Here, so what I'm asking Praveen to do is, I'm asking him to push the head superiorly. So he's just not pulling, pushing anything. He just push that is inferior subluxation is being corrected. That's all. So that is that way my inferior capsule tightens up nicely. Now after that I do some half hitches. My sliding is over. There we go. And then put it. Yeah. There
You
we
always
go.
put the inferior one last.
Yes. I sometimes I basically have to put it after the 5 o'clock anchor. That's all. I can do it anytime at the 5 o'clock anchor. So one because then I'm not bothered about the you know passing the sutures and the scorpion, and I'm not worried about it at all. Right. So we are done with that. So I'll just switch. I'll show you the remplissage. So here you can see why did we pass the remplissage sutures earlier? Because you can't see any hill sash at all now. The head which was actually dislocated anteriorly is completely centered now. So here you can't see any. That's why you should always pass off the anchors initially itself and keep it ready. So now it's going to be little blind. So here that is where your remplissage is. Hold on. What is it? Separate.
That now that the head is centered over the glenoid, can we live without the remplissage for this patient?
Okay, so now then we have to look at the statistics. So what is the redislocation rate without remplissage? So without remplissage, it is around 21%. With remplissage, it reduces around 8%. So definitely, why do you want to take a, and if you look at the maximum redislocation rates, it varies from 20%, 30%, that kind of data we have. So if you do, the point is the patient should not come back to us, and we should not, why to give him one single surgery with under 5 minutes extra, where you're going to fix one anchor and tie it up so that you don't have to bother about it. So this door, in the paper I showed, when the morning lecture I showed that in the paper, only 10%, 10% or 10-degree deficits were there. That too in very few patients. That is around 4% patient had excitation deficits. So that's a very good number for us. So from my side, my instability rate is 2%. That is recurrent dislocation rate is 2%. My excitation tightness percentage is 4%. So why not? So that is the answer. So here, this is basically a blind technique. You can see how you got a hit like this. See how you hit. I'm going and hit like this. That is basically the tendon is coming onto the hill sash area. Then I am actually skiving it. I'm withdrawing it, sliding and skiving it. So light on madakle. So I think in our surgeries, we should do, if we can do something as an extra step to make it more stable, why not? I think we should do that extra step. Why save, just, why give anything to chance? Hold. And one more important thing was, so this tracking is, that's what I was trying to say. It's not an absolute concept. It's not like, it will track only through like this. This tracking is for a regular movement of the shoulder. It is not for a very, very abnormal, sudden movement of the shoulder. So, so right now, so we did a study where what we did was we did something called distance to dislocation. It is that paper is not published yet, and where it is shown that if the track to the edge of the glenoid, that is the distance to dislocation. That means you know the track now. From the track to the edge of the glenoid, how much is the distance? So if the distance, that is called as a distance to dislocation. It can be 5 millimeter, 10 millimeter. That is distance from the track to the edge. If the distance to dislocation is within 10 mm, it's supposed to have more chances. So there is an American study on it. So we had done a similar study to that, and on this distance to dislocation concept. So it is a very, very new concept. It is. I hope some you are able to read that paper on distance to dislocation. That will actually change our thought process on this remplissage, the tracking, and all that. But ಕೇಳ್ಕೊಡಿ ಎಲ್ಲ ಹೋಯ್ತಾ ಜೊತೆಲಿ ಒಂದೇ. So here I've finished off the remplissage. You have to feel the knot and then come back. It's all blind. You can actually do this as under visualization also. Right. So we finished that. Okay. Missing a rod? Missing a rod. Okay. So we'll go posterior now. We'll see how the anterior is. Right. Ah, right. So that is where the repair construct is. So I think that's pretty good enough. I don't think I want to put, because already on the superior edge. So it's quite stable. Uh, I can do an RI closure, but I don't think it is required. This is so very stable. So I just leave it alone, I guess. So that's basically it. So basically, my three anchors, 1, 2, 3, and then the Hilsash finish. And yeah, any questions?
Yeah.
Sir,
Any questions from the audience?
Sir, what will be the post-op protocol for this patient, sir?
Yeah, post-op protocol is like, so we're coming out now. Yeah. So first 10 days only elbow flexion extension exercises. And no shoulder movements at all. From the 10th day onwards, after suture removal, we patient in supine position, we start with active assisted, with holding both opposite hand, active assisted forward flexion to 110 degrees. Maintain for, that is, till the third week. Gradually increase to 180-degree forward flexion in supine position by sixth week. External rotation of 10 degrees only, and internal rotation to scapular plane. Isometric strengthening exercises. Isometric cuff strengthening, deltoid strengthening. So this is the protocol till sixth week. After 6 weeks, strengthening in supine position. When the patient achieves at least 3+ power, then we go on to strengthening in standing position. And the external rotation, we increase to 45 degrees after the sixth week. Normally in our protocols, the patient will achieve their full range and power by around 12 weeks. And very rarely is there any stiffness. So some patient can take a little more time from the 12th week onwards, maybe under 1 month more to achieve their full external rotation. But that's a protocol.
Thank you very much, sir.
Thank you so much.
Any 2 double-loaded anchors are enough, simple? Always need 3 anchors.
Yeah, always 3 anchors. Yes. So if, because the double loaded actually helps us with more tissue plication, more capture points. So why not double loaded? It'll basically 1,000, 2,000 rupees more.
Okay.
Shall we go
Hello?
offline? Thank you so much.
Dr. Nair, sir.
Thank you.
Hello?
Hi, yeah.
Nice. Dr. Srinivas here.
Hey, Srinivas.
Thank you so much, sir. I think you have utilized the entire 90 minutes completely. You have shown every step very nicely. So I think no one has moved out of their chairs for the entire live surgery. So it was wonderful. And I think anesthesiologists have done a great job. Absolutely bloodless
Absolutely, madam.
field.
Thank you so much, madam.
Absolutely bloodless field. And also Dr. Vaibhav, Dr. Surya and Dr. Rajesh has done beautiful work behind all this.
Absolutely.
Thank you, sir.
It is very,
Thank you
very
so
cordial.
much.
I should really thank you
Wonderful.
all, because
Thank you.
very humbling, and everybody is so very nice, so very caring. I really appreciate
you.
all your hospitality. Thank you so much.
Thank you. Thank you so much.
Thanks.
Sir, I invite Dr. Raghavendra to present the mementos of the moderators.
Thanks, sir. Thank you. The report.
Next will be a short 15 minutes of panel discussion on instability, and then we'll break for lunch for just 30 minutes. And then we'll have another live surgery at probably 2:30. Six chairs. ముందు వాళ్ళని పైకి మార్చేసి Hello. Yeah, I invite Dr. Chirag sir to come out to the stage for the panel discussion. And Dr. T. Ramanamurthy sir. Ramanamurthy sir. Dr. P. Ravi Sharma sir. I invite Dr. Ashish sir to moderate the panel discussion, be presenting 2 cases.
Hello. Check, check. Check. There.
Good afternoon. And that was really a wonderful session of live surgery by Dr. Iappa sir. He made it bank art and remplissage look so simple and so easy actually. Firstly, I would like to congratulate the team of our friends Srinivas and Santosh and Rajesh for doing a commendable job. They organized such a wonderful conference. I think shoulder conference, I think it's maybe 3-4 years back, I think we had a shoulder conference. So we needed this. So we really had a very wonderful session in the morning. And let me start straight away start with the cases. Kindly bear with me. I've been running flu since couple of days and my voice has been gone. So this is the first case. A 30-year-old guy. He had a pain in the left shoulder and occasional giving away sensation since 2 years. His complaint started 2 years back while he was playing cricket and he had a injury and dislocated. This shoulder was reduced in the hospital, and later events he had frequent sensation of giving away while playing, and totally he had 2 to 3 episodes of dislocation in these 2 years, and 1 episode of dislocation was reduced spontaneously. He is a bank employee by occupation, and he's not into serious sports, but he's a recreational sports. With this is history, like I would like to just ask the panelists, like, what can we think about the lesion, or what can we expect about the gravity of the situation? Is it a mild injury kind of thing? Do we expect any bony lesions over here? What is your take on this? Just seeing his occupation, age, and the mode of injury. Can you throw some light?
So looking at the history,
Yes, sir.
He might be having soft tissue injury as well as attritional bone loss could be a possibility. The only last episode was reduced spontaneously, right?
Yes, yes. Only one episode.
Any other examination findings?
Yes, yes. I'll go on to that. Just please.
Could be an indication for generalized laxity as well, the spontaneous reduction.
Yes, yes. But the event started with a traumatic.
Okay, but he could be having pre-existing
Yes,
generalized
yes.
laxity. So that spontaneous reduction is a indication that we have to look for the joints as well.
Sure.
And calculating a SS score will be very ideal before we go for surgical decision.
Fine, sir. Ramamurthy, sir.
It shows traumatic unidirectional instability because it's happened 3-4 times in a 2 years time. And spontaneously reduced means its capsular stretching is also there. Most probably a soft tissue issue is the more problem in
Yes,
this
sir.
case.
It's a traumatic unidirectional kind of injury, and most probably we can expect here a Bankart's a soft tissue lesion, and with a bony lesion also. But I think I'll just go ahead with the examination point. There's no gross wasting and no obvious deformities and all. And even the range of movements are all also nearly normal. And coming to the specific test, I generally prefer doing an apprehension test. And the apprehension test here is positive, and even the job relocation test was also positive. You can do other tests also, especially the sulcus sign and all. If the laxity is very gross, then we can appreciate the sulcus sign, which is not positive over here. So just to complete the examination is always better to check for the neck, upper back, and even it's always better to examine neurologically. Did he have any injury to the brachial plexus or to the axillary? Now, here it was normal. So, and even the generalized laxity was also not there. This is the only X-ray I have. So, what do you comment on this X-ray? Though it's only a single image, I don't think so. We can. The only thing we can comment here is I think there's no gross.
No gross bony lesion as such.
Yeah, bony injuries are not there. Maybe erosions are also not there. So that's the only X-ray I have. Well, going to the MRI. This is the MRI. I think we can. If you read the MRI, there is contusion over the posterior superior aspect of the humerus, and maybe from 4 o'clock to 6 o'clock, the glenoid labral tear is there. So I'll just go ahead with the CT also, sir. You want to add anything over here? Anyone?
Now, from the available information, I think there doesn't appear a big Hill Sachs. It's just a soft tissue Bankart. So probably we would plan a simple soft tissue Bankart's repair. Maybe Remplissage would not be added for this.
Yes.
That would be the primary plan.
Fine.
You have other images?
Yes, sir.
Coronal.
I don't have the other MRI
images.
This is the CT. Nowadays, even for minimal dislocations, like 2-3 dislocations also, it's always better to get a CT done. At least you'll be able to know the bony loss, how much it is, you can quantify it. So I did a CT. CT doesn't so much. There is definitely a minor Hill Sachs is there. So these are the findings. So the Hill Sachs is almost like 1.5 centimeters anteroposterior and 0.3 centimeters mediolaterally. The bone loss is like measured on the CT is like 10.7%. So it's an on-track lesion. So I think, is there any take on conservative management in this patient?
I think any episodes more than one is not an indication for conservative.
Even if he's not a sports person?
No.
No. Fine. Everybody, I think we'll all agree to that, because once a single dislocation, I think if he's young, then I think there are, the literature says that 85% to 88% there is redislocation chances. So I think we should fix it. So what is the criteria which we are looking into when we are planning any surgical procedure? So this guy is a young individual, non-dominant hand is its left side, and doesn't have any like physically demanding sporting activities and all. He's only a recreational player. And the number of dislocations, there's no laxity, and the bone loss is 10.7%. So I think we would get away with a soft tissue procedure. I think everybody will agree on to that. I'll just rush through just the video a little bit. This is the viewing from the posterior superior portal. From the anterior superior portal, where you can visualize both the humeral side, posterior side, and the anterior side. So, sorry. The Hill Sachs is not that significant over here. So you can see there is a dim depression. When you view the labrum, I think you can see there is a tear in the labrum. We try to elevate it, go up to beyond the tear, elevate up to even the normal labrum also. So that is what we have seen all this in the live surgery actually. So I'll just rush through it. So the main important criteria here is that you release your labrum until it's sufficient enough to bring it back onto the glenoid. I just wanted to share one thing. When I was drilling this, there was a very unusual, strange, and shocking incident which happened. The drill bit broke actually in the cannula, in the sleeve actually. So never heard of it and never had this. So just wanted to show our delegates that shoulder surgery is like any other orthopedic surgery. It's not an easy thing. So you need to be ready with for the complications. And somehow with great difficulty, I could retrieve that drill bit. I was lucky that the drill bit was slightly proud. It broke outside, and even it was like holding onto the glenoid. If it was not holding, or like I would have lost it in the dead space, then gone. So that's a very big drill bit, which I could retrieve it. The rest of the procedure, I think we all know, we through the lassos take good bites and couple of anchors. Second anchor, then these are the knot tying. So I think 3 knots, and after the tying, you get a sufficient shift of the capsule onto the glenoid. I'll go ahead with the second case. 38-year-old gentleman, similar complaint of discomfort in the left shoulder and giving away sensation. Since 4 years he's suffering. And he had an injury started 4 years back. He had a dislocation directly fall onto the shoulder while he was driving on a two-wheeler. The history goes like this. There's frequent history of giving away, loosening. The second episode happened with just a trivial injury. And later 2 episodes were like just spontaneous in the activities of daily living. He dislocated. He's not giving a classical history of dislocation actually. Almost like he's telling that the shoulder is going out and coming back in. And one of this episode happened during the sleep. So he's again not a sports person. He's just a working class guy. He's just a salesman. So what can we make from this history, panelists?
It is this a major injury. I think it's a road traffic accident, you said.
Yes.
Maybe you can expect an anterior bony Bankart, maybe.
So one episode was in the sleep. So
yes, the last episode was in the sleep.
Last episode,
that,
he said.
that shows that there is a severe capsulolabral injury, or could be a bone loss.
Yes.
Significant.
The history, since there are increased number of dislocations, and with very easily trivial trauma also is getting dislocated, then we can expect that the laxity is more, and even of course there might be both bipolar lesions, both the glenoid and the humeral bone loss should be there. There was a significant amount of wasting and on clinical examination. though the movements were almost like normal, the apprehension was around 80 to 90 degrees of abduction and external rotation. There was apprehension. So
Not below that.
not below that.
Okay.
So almost like 80 degrees and beyond 80 degrees, he was having
I'm
apprehension.
talking about abduction.
Abduction and external rotation.
No, what degree of abduction he had?
80 degrees.
80 degrees. Okay.
And what kind of vesting was there on left shoulder?
Pardon?
The vesting of left shoulder. What kind of
Wasting was
vesting?
there. Maybe I think there was nothing. Others, other examination was normal. It might be a disuse.
Actually, I'll tell you, we tend to miss axillary nerve injuries quite often. We find that only after a few years that when there is a gross wasting of a deltoid, that we assume that he might have had an axillary nerve. Actually, also, no, few cases we tend to miss. So we have to always assess the axillary nerve in the first place whenever we are examining. But because now we usually tend to overlook the
Yes.
axillary nerve.
Because generally we look only onto the MRIs and the
Yes,
X-rays,
yes.
and we forget
The-
about
because,
neurological aspects.
Yes, the wasting will take a lot of time. Maybe after 6 months or 8 months, then we might think retrospectively that we might have had a axillary nerve injury, which might have been later.
Here actually,
maybe in this case, I think mild wasting a non-dominant hand, okay, it's considered. But as he said, axillary nerve is very important to examine and rule out that lesion.
yes. So here it was like we examined him neurologically also, like he didn't have any axillary or brachial plexus injury. So
Here,
this
apprehension during abduction of 90 to 100 degrees, you said.
Yes,
That is against of maybe a bony Bankart here, maybe a bipolar lesion, what you said.
Yes, yes.
If it is happens in a 45 degrees of abduction and external rotation, you can consider a more lesion than a soft tissue we can expect. But 90 to 100 degrees, whatever, the soft tissue or bony, it will give you an apprehension.
Fine. The apprehension test, same. The job relocation test was also positive. And the other examination, neurological examination, was normal, and even there was no generalized laxity. When coming to the imaging aspect, the X-ray, I think here we can see
Hill sacks. Yeah.
there is a significant obvious hill sacks on the X-ray. So MRI, I think, shows us the soft tissue. Can you just Ravi, read the X-ray? Sorry, the MRI.
MRI.
Fluid and Bankart.
The anterior-inferior Bankart is like elevated, displaced, and I think it's like an alpha lesion.
Also there.
Yeah. So this is the other MRI image. I don't find anything more. There was a concern that there might be a slap tear, but it's not like that clear, crystal clear.
It seems to be a bit of a J sign as well.
Pardon, sir?
J sign.
Yes.
That our inferior glenohumeral portions.
The classical pouch is not there actually.
Okay. Okay, this here in this section. Okay, fine.
I'll go ahead with the CT. Here, I think we can see significant amount of hill sacks. And when you go down, 6 o'clock, maybe 5:30, there is the rounding off of the glenoid, anterior-inferior glenoid is there. So the bone loss was like quantified on CT as 17%. And it was like on-track lesion. That was what the report suggested, and with the calculation. So what do we plan for him? He's not a sports person. He's a middle-aged guy, and
Still in the, okay.
Sir, please.
I would do Letarjet for this.
In this case, I prefer Letarjet, open Letarjet, straightforward.
I would like to do arthroscopic encirclage, bony encirclage, and remplissage.
Fine, sir.
I prefer doing an arthroscopic Bankart with remplissage. Letter J, I would reserve unless there is a glenoid bone loss, because there is sufficient literature which says that the graft will get resolved if there is no bony lesion on the glenoid.
Fine.
In this case, he commented about glenoid bone loss about 17%, you said. So
Yes.
that is a pretty indication for letter Z, to my opinion. Of course, a bony resorption is an issue after 2 years, maybe with the screws and all what you said. Correct, but in my hands, I have a couple of, many of the letter Zs, they are all fine, even with the movement and all.
I just wanted to know the criteria from the panelists, because since past decade I have been doing shoulder. Earlier it was 25% of glenoid bone loss. Now I think when I went to the
Now
literature also, it was like 20% couple of years back.
Consensus is 15%.
I think it's pretty clear now. 13.5 to 20% is subcritical, and you have an option of Bankart as well. Anything more than 20 is clear cut bony, but 13.5 to 20 is here and there.
It's a gray area.
Gray area.
So that is what I do. If it is 20 or more than 20%, then I would use coracoid and do Latage. So that will provide the dynamic sling as well as the bone block. If it is less than 20% in subcritical zone, then I would use either the spine of scapula or iliac crest as a bone graft and do the encirclage.
And I think we need to take into account the age and the activity level of the, that also is, I think, plays an important part. Only concentrating on the MRI and the CT findings, we need to discuss with the patient also, and what are his demands, and what are his activity levels and all, and what he wants to gain after the surgery, what he wants to do. So finally, I counseled him for Latajet. I do an open procedure. So he was kind of reluctant, and he came to me after, I think, couple of 2-3 months later. I don't know, some shopping went or whatever it is. But I took him straight away. He was convinced only for a arthroscopic procedure. So he said he don't want to do any, I'm just a salesman. I just sit in a shop. I don't do any physical activity. I don't want an open procedure. With the risk of a redislocation, I explained him and took him for surgery. My plan was to do a Bankart with a remplissage. This is the amount of shift translation of humeral head he had, and the hill sacks was like quite significant, and even there is erosion of the. What should I have done? Of course, here the patient is not agreeing. If we see this kind of picture, intraoperative.
That is what I told. No? Arthroscopic bony encirclage along with the remplissage. That was my first choice for these patients. So you can augment the bone anteriorly with either the iliac crest or the spine of scapula. You fix it with the encirclage suture taps, and simultaneously you could do the remplissage. So all procedures are arthroscopic.
So no need to convert into an open Latage. Fine. I went on and did the remplissage and the Bankarts actually. Fingers crossed.
If I find a situation where I feel that letter J would do better, if I've already put a scope inside, I would do a remplissage first and then come back and do a letter J for him.
Both. Remplissage and Latage.
Because anyway, I've gone inside. I would like to give him the benefit of the arthroscopic work. I'll definitely do a remplissage followed by a letter J.
Because I felt bad seeing this image. I wanted to do an open Latage, but I felt bad when.
What he says that arthroscopically you can do the remplissage and you can do the arthroscopic
That's what. That's
Extra benefit in the sense it is a bipolar bone loss. So it is ideally better if you address both.
You are addressing both the
issues.
hill sacks and the.
Preoperatively, we decide and say we are doing only letter J. Maybe we can skip on the remplissage. Since we have already decided.
Somehow I like.
For the first case, would you prefer an open Bankart because you're having
I went on with the remplissage and the Bankart's repair. I felt like I should have done a Latager procedure. Fingers crossed, it's almost like 6 months. So let's see how it turns up. Though I have counseled him a lot.
How was the tissue?
Quality of the
I
tissue.
think you can see the tissue was not that great actually. So had to do a lot of elevation. It's almost like Alpsa. Tissue was not that great. I think I'll show you before elevation. There's no tissue at all. Like it's completely fallen down.
If there is no tissue, it will fail always.
Yeah. So after sufficient release, I could pull the inferior capsule and this.
Subcritical bone loss, DAS is another indication where we could add up DAS along with the Bankart repair.
Somehow I could get the inferior capsule nicely onto the glenoid, and after sufficient release, initial of the procedure, we see there won't be any tissue. But when you do a good amount of release, you can pull back the capsule and even the IGL and try to bring it onto the glenoid layer. So somehow I'm waiting for the.
This kind of situation when we have, what I do is, see, patients always have a lot of information and they decide the treatment and come back and they demand for a particular type of treatment. So with their limited information, they have decided treatment, and with available information for us in the OT, it is our job to decide what we want to do. Let him ask what he wants to ask and we do what we want to do, because at the end of the day, we are also supposed to be peaceful depending on our result which we are going to give.
I was not expecting this arthroscopic image.
That's what I'm telling. After you have an intraoperative available information, you are the person who's going to decide it. It is better you tell him that this is what is to be done and I'm going to do. Because you do what you do, let him ask what he asks.
The consent of the patient is important.
That is
that is what.
Take a decision.
You can't force on him actually. So at least that decision making part should be not in the OT. It should be in the OPD actually.
Finally, inferior capsule is pulled to the superiorly, isn't it? In this case, what you did it in? Labrum is not there. You said capsulorrhaphy type.
Yes. Somehow I could get a good repair. I pulled all the inferior capsule and the anterior capsule and whatever labrum was left.
Fine.
So the total 3 anchors are used, and I'll hope. I was thinking that I did a decent job. Then we have to wait for the result.
So just need to ask him to avoid a bit of a lot of action.
Yeah, that is already.
And you need to focus a lot on the scapular muscles for rehabilitation.
Fine, sir. Thank you. The discussion is over. I've got 2 cases.
Yeah. So thank you, sir. That was a pretty good discussion. And I think regarding the bone loss management, I think we can come to a relative conclusion that if there is no significant bone loss, go for soft tissue repair. If there is critical bone loss, go for bony procedure Latarje. The gray zone where the subcritical bone loss of 13 to 19% or 13 to 20%, there we can do soft tissue repair, add a bony augmentation in the form of scapular spine bone or the iliac crest.
The glenoid bone loss and the humeral.
Exactly. And for that subcritical bone loss, I have gone through a paper where they have shown very good results with open Bankart's repair. Okay, so they have given 2 options: either go with soft tissue repair arthroscopic plus a bony augmentation, or go for a direct open Bankart's repair, and they've shown very good results with open Bankart's repair in that particular.
Srinivas, in a gray zone, why not straightforward Latarjet with a coracoid?
Obviously, sir, we can go because there are many
augmentation and going for this labral repair, whatever the tissue is not available and straightforward, we can go for the coracoid. Is there any strong region nowadays?
Lateral has its own complication. On long run, there are higher rate of arthritis.
Arthritis,
and all
exactly.
those things.
All the bony procedures, that is the, because
Well, arthritis
technically
is not
high
an issue. Basically, most probably it's resorption is an
Technique
issue.
is not
depends
an
upon
issue.
the
You have already
experience
been
of the surgeon as well,
well
right?
versed with the
Because the number of
technique.
surgeries we do, obviously.
How well you
Technique of
prepared and
lethargy is
heat.
not an issue.
Yes,
We are
yes.
all well versed with it.
Yes, it's the gray zone is the most debated thing. No, you
That-
can go for.
Sir, even there are many surgeons who do lethargy even for the first time dislocation. Also.
Thank you very much, sir.
Sir, so I would like to invite Dr. Marthi Krishna sir to please give the memento to Dr. Ashish Garu. Great job by Ashish sir. Sir, I would like to invite Dr. T. Ramamohan Garu to please present the memento to Dr. Ravi Sharma Garu. So now we'll break for lunch. We'll start the second live surgery sharp at 2:30 p.m.
హలో ఎవరు ఓహో దీనికి వెళ్ళిపోయిందా సార్
Hello. Hello, check 1 2 3. Hello.
కనిపిస్తున్నానా ఒక్క నిమిషం నేను మాట్లాడతాను నాకు ఒక్క నిమిషం వినిపిస్తుందా రాయేష్
Yeah.
సార్ we'll be streaming in 5 minutes sir everybody is assembled inside
సార్ మై వాయిస్ ఇక్కడ థియేటర్ వాయిస్ వినపడుతుందండి
సార్ ఆడిబుల్ విజయ్ కుమార్ గారు
ఓకే థ్యాంక్ యూ అండి థ్యాంక్ యూ సార్ రైట్ అండి
అది ఇక్కడ ఒక 5 minutes లో స్టార్ట్ చేస్తాం అక్కడ
కాదు ఏంటి 5
రాజేష్
minutes వెయిట్ చేయమని చెప్తున్నా ఆయన్ని
డాక్టర్ రాజేష్
వినపడుతుందా
అదేంటి ఆల్ సెట్ అంటే చెప్పి ఇక్కడ మేము ప్రెజెంటేషన్ స్టార్ట్ చేస్తాం
మేము ప్రెజెంటేషన్ స్టార్ట్ చేయండి ఆయన స్క్రబ్ అవుతున్నారు
కదా ఓకే రైట్ విల్ రైట్
యూ స్టార్ట్ విత్ ద ప్రెజెంటేషన్ ఆఫ్ ద కేస్
बीच में इसमें फोटो लेना
Can you just speak? You cutting. Can you speak?
हेलो
Audible, Santosh? Sir voice audible, eh? Is sir was audible, Santosh?
వచ్చి
हेलो
వచ్చి సెకండ్
सेवन एंड हाफ 7.5
Just teaser waited.
You have powder free? Wait.
ఇప్పుడు ఆటోరం వ్యూ వస్తుంది కదా అదే నా ల్యాప్టాప్ ఉంది కదా దానిలో వీడియో ఆపే ఇప్పుడు ఇప్పుడు రెండే వస్తున్నాయి కదా స్క్రీన్లు పిన్ చేసేసుకోండి స్క్రీన్లు ఎందాక ఫుల్ ఎలాగొచ్చినా పర్లేదు మనం తీసుకోండి
हेलो
ఆల్రెడీ ఓటీతో మాట్లాడాను నువ్వు పెట్టే కేసు
Thank you.
నేనే
Yeah, that's fine. What are instruments we have?
రాయేష్ సీనియర్ లెగ్ స్టేజ్
So second live surgery is about to start. Moderators live surgery. Dr. Raghav to come up on the stage. Dr. Ashish. Ashish.
Hello.
What is
Yes, Dr. Srinivas, everything's ready here.
Yes, sir, just 1 minute.
You can go ahead
Just
with the
present-
presentation.
I'll just go through the case details once.
Sure. But your screen needs to be switched on. You're not, yeah, now it's visible. Right, done. You can go with the presentation. Yeah.
Yes.
Please go ahead.
Yes. So basically this gentleman is weaver by occupation, 28-year-old. He had 3 dislocations, just like the previous case. One in 2018, second 6 months back, and one, the last one was 1 month ago. So his shoulder MRI shows a tear of the antero-inferior labrum, and he also has a tear of the inferior glenohumeral ligament, and his CT, the bone loss, glenoid bone loss is 9 to 10%, and he had a on-track Hill-Sachs lesion and a non-engaging one.
Where is the form
So
people?
over to you, sir.
Which one is the sleeve for 1.5 mm anchor? Who is from Ceronics? Who is from Ceronics? You just prepare with the, where is the sleeve for 1.5? Okay.
And another one is 25 degrees.
Hello?
12.5.
Sir, are we audible?
Okay. Cannula introducer.
Sorry, sir?
Cannula handle.
Yeah, cannula introducer. Okay, picture. This is the 8.5. And
Okay.
6.
Fine. And this punch is for?
This is for rampless filtration. It
I
depends
am?
on the bone quality. So if it is bone quality,
This is for 5.5 mm?
4.5, 4.8.
4.8.
Yeah.
Double loaded. Okay.
Sir, are we audible, sir?
Yeah.
Yes, yes.
Can you see
Yes.
us?
Yes, sir. Yes, sir.
Yeah. So I am just, you must have gone through the history and images of these patients. So I am just starting with the marking of the surface marking and portal marking of this patient. So that is the most important part, because portals are your best friend, but if they are not taken properly, they are your worst enemy. So I usually start marking from the posterolateral angle of acromion. Just go posteriorly like this. Just palpate from soft towards hard. So this is the lateral border of the acromion and clavicle, and this is the posterior margin of clavicle as well as interior margin of acromion, right? So somewhere here lies the coracoacromial joint. Then anterior bony prominence is coracoid. Somewhere here will be like your CA ligament. So my posterior portal will be slight lower and lateral as compared to I use in rotator cuff surgeries. So in rotator cuff, my portal will be somewhere here, but for Bankart, my portal will be somewhere here. Okay, so this is posterior portal. The anterior portal is just lateral to coracoid, and that is anteroinferior portal, and just at the anterolateral edge of the acromion will be my anterosuperior portals, and these two anterior portals will be taken through the outside in method using needle. Okay. So I am taking my posterior portal first. Trocar sheet, please. Air निकाली है. follow. Hair निकाली है ना? हाँ. Okay. So now the entry, I don't use the artery forceps to dilate the pathway or to penetrate the joint. I just feel the glenoid and just roll over it and palpate the depression in between. Just lift a little bit, sister. Okay. And there is a depression. I just soft sports. I enter the joint. Okay. I think there are some marks on the scope. Okay, fine. So you can see the biceps long hair, that is the lighthouse of the shoulder joint. So this is the long head of biceps. This is the subscap. This is the MGHL, which is, I think, pierced with my trocar sheath. So you can see a little hole over here that is pierced with my trocar sheath on first entry. So this is biceps, lift a bit. You can not see any lateral soft tissue anteriorly. Just I need to clean a little bit. Okay. So this is the axillary pouch. This is the postero-inferior labrum. So essentially, this patient is having a lax shoulder. So this is a kind of cinema hall view. Normally, you are not able to watch or visualize the posterior labrum through the posterior portal nicely like this. So this patient has voluptuous capsule and lax shoulder joint. So that is the one reason you can see the posterior part of the labrum and posterior capsule even from the posterior portal, right? So this is the attachment of supraspinatus. This is the long head of biceps, which is entering anteriorly. This is a sort of, you can say, SGHL, that is superior glenohumeral ligament. And if you see Hilsek is pretty large, huge Hilseks over here. So my plan is to put first anchor for the remplissage, and then I will go for Bankart repair, and if required, most probably I will do some tucks or the plication and the postero-inferior capsule also in these patients. Needle, please. So your portal, your needle should be through the apex of this rotator interval triangle, not too close to the subscap. You just check the trajectory. You lift a little bit. You will be able to put the anchor at around 5:30 o'clock position, right? Relax. Knife, please. Leave it, leave it. Remove the needle. So I am entering the capsule with my knife. So I will dilate the capsule with knife only, where I need to put my 8 mm cannula. Okay. Cannula, please. Yes. Go in. So you need to be careful. Okay, that's fine. Remove the handle, please. So don't dilate the skin incision too much. Otherwise, your cannula will be just jutting out and you'll be struggling throughout the surgery. So keep it small just to negotiate the cannula. Okay. Now I will put my second portal, which is anterosuperior portal. It will like I can go back and forth of the biceps with this portal. Knife, please.
Chirag, sir.
Remove the needle. Yeah.
One question.
Yeah.
How do you avoid the crowding of the two cannulas, anterior and anterior superior?
That I will show you. I normally use anterosuperior viewing portal for the remplissage as well as to just prepare the labral tissue and glenoid. Then I will use the posterior portal as the visualization portal and anterior anterosuperior inferior portal to pass the sutures and tie the knots. So I will be viewing through the posterior portal and working through the anterosuperior and inferior portal for the Bankart repair.
Oh. So you will be working,
right?
So you will be viewing only from the posterior portal.
Yeah, during my Bankart. So
During
I will.
Bankarts. Fine.
Switching state.
Do you have any experience doing this procedure without the cannula, sir?
Without? Come again?
Without using cannula.
Cannula, no.
Cannulas, yeah.
So cannula is must for the Bankart repair, but if I am doing the posterior Bankart, the posterior labral repair, I do it without using cannula. The sheath will go through this cannula. Okay. I need to put a skin.
What is the size of the cannula which you are using now, sir, for the anterior superior portal?
Wait a minute. Wait. Okay, fine.
Chirag, sir, what's the size of the cannula which you are using now?
The lower one, which is in the anteroinferior, is the 8 mm. Give me the orange, the green troca. And what is the size of this white cannula?
6 mm.
The other one is 6 mm.
6 mm. Okay.
Fine. So now I will shift my scope to the anterosuperior portal. Needle, please. Now I will check my trajectory of putting the remplissage anchor So this is quite a low. I need to put my anchor a bit like let me clear this bubble. Okay. So it looks like very large hillsacks. Maybe I will be using two double loaded anchors. I normally use peak anchors for the remplissage and all suture anchors for the bankart repair or lateral repair. Okay, knife please.
You are creating another portal, sir?
Yeah, I am using another portal for the remplissage. I need a cannula 6 mm. Remove the needle please. Okay, go. Okay, fine. Come out. Can you give me a rasp? Up. So I will prepare the remplissage area, the hillsack defect, with just liberating or elevating the soft tissue kind of thing, just abrading a little bit. I don't want to deepen it much. So I just make it bleed a small using rasp like this. Anchor please. Punch. So I'm planning to put two anchors, one over here, just close to the cartilage articular margin, and one over here, right? So one is inferior, one is superior. Hammer please. Go. Fine. So this is the owl for 4.8 mm. So you need to go up to the okay. Hold the cannula please.
Is it a 5.5
So
peak anchor?
usually I use 5.5 mm anchor. I didn't know about the 4.8 mm anchor from Xeronix, but this guy from Xeronix told me that it is available. Then why not, right?
So this is a double loaded anchor.
Yeah, this one is double loaded. So good. Now give me the penetrating rasper. So I'm planning to go from east-west direction for amplissage suture passage. So this is the saline, please. It is there, no? Okay.
Is there any pattern or order in which you take bites, like from
So
inferior
I
to
start
superior?
from
or-
inferior and then go superior. I start from the lateral most and then the medial one, right?
Fine, fine.
No other one, yeah, pull it. Fine. Leave it a little bit.
I think you need to be careful to prevent the offloading of the anchor.
Okay.
Yes.
Hold it. Remove this. I need to pull out the cannula. Wait a minute. So what I do, I want to prevent the entanglement because this procedure is blind. I will remove the cannula. I will just tag these sutures with the artery and switching stick, please. I will reintroduce the cannula again. So the sutures will not entangle with the second pass. Hold it, please. Wait. Okay, come out. Punch. Sure,
Dr.
please.
Chirag, what is the size of the cannula which you are introducing?
What?
What is the size of the cannula?
What they are telling?
Size of the cannula.
The posterior cannula is same as the anterior superior 6 mm.
6 mm. Can we avoid the cannula passing through the cuff? Can we directly do it? Because we are all, I think you have taken almost 4 bites for the previous anchor. And again,
So
another
if
anchor.
you don't use cannula, you may take bite through the deltoid muscles and that will be very painful. So you don't want to catch the deltoid inside the remplissage bite. So that is why the cannula is required.
Catch the deltoid. No, while passing the anchor, we don't have to.
Then when will you put the cannula? Once you have passed the anchor, then afterwards you can't put the cannula. Okay, go. Go, 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 go. Go. Okay. Remove it. Pull it. So now I will retract the cannula a bit. I will swipe it above, below, sideways, right? So this is the tendinous portion best to be used for the remplissage. So I have seen the Sugaya who is switching between the subacromial space and articular side while passing these sutures, but it is a difficult and time consuming job. So I just pass it blindly. I am not visualizing the subacromial space while doing this remplissage. Okay. Use the blue one, no? So sometimes you need to park the suture superiorly because once you pass your bird brick, you may not able to retrieve in that angle. So let me try this out like this. Yep. You should be always watchful while pulling the past sutures. So you should not accidentally unload the anchor. So from distal to proximal, or you can say from caudal to cranial, and from medial to lateral. That is my sequence of passing the sutures. pull the blue one. Yeah. We need this cannula out. Sister, hold it. Thank you. So our remplissage suture passage has been done. Now we will be focusing towards the glenoid preparation. So you can see there is no tissue at all at the glenoid neck even. So it is the kind of ulcer lesion. Elevator please. So normally I start from above to below. So it is almost a 2 o'clock position. Emma please. So this is the only step in Bankart repair where you will encounter bleeding. Hammer again, please. Hammer, please.
Chirag, sir?
Yeah.
Chirag, sir, how will you decide the extent of release? Like
You
when you will
want
think that release
you want to say
is enough?
medially or inferiorly? So
Inferiorly.
medially up to the belly of the subscap is visible. Inferiorly up to 6 o'clock. I am little bit less aggressive. I don't want to go beyond 6 o'clock position. I don't want to cut the normal labrum. No. The
Because
down
some
one.
people advise to go beyond the tear and go up to 7 o'clock and all.
Come again?
Some people advise that it's better to go beyond the tear. If the tear is somewhere around 5:30, 6 o'clock, go beyond up to 7 o'clock and release the labrum, the normal labrum also. What is your
That is
take
what
on that?
I told you. I am little bit less aggressive. I am happy with the release up to the 6 o'clock only.
Fine.
Fine.
When you release, I think bleeding is very a normal scenario.
That's fine. So this is normal. It will settle. You need to have a little bit of patience, and it usually settles in a time. Emma, please. Emma, please. Lift a little bit, please. Emma, please. Go, go. Okay. Emma, please. So I am almost at the 6 o'clock position. You can see here,
Yes, yes.
right?
Yes, yes.
So I don't want to cut the much intact part of the labrum. I will rather shift the capsule a bit, and maybe I will take 1 or 2 stitches
Tissue
in the
looks
posterior
more
capsule. You can
friable.
see now, relax. The entire the capsulolabral complex is floating. Ice tongue, suture manipulator, please. So you need to check whether your labrum is released properly or not. You can give me, yeah. You can see nice reducibility of the capsulolabral complex.
Yes.
Okay. RF, please. RF foot switch, please. So I just need to take a little bit of this loose soft tissue. Lift it, please. I need a curette. No? Any other curette? Okay, give me
Chirag, sir.
liberator.
Chirag, sir.
Yep.
How is the quality of the tissue?
The quality looks good. It is not bad.
Okay.
So I need to make this area where I put to anchor a row. We don't have the ring curette. Let me try the other one, this normal curette.
How many anchors you will be planning?
Yeah, I am planning 3 anchors on the anterior glenoid side. I will be using the simple technique, using 1.5 mm all suture anchors, using simple
Single
suture
loaded?
configuration. I am a simple man.
Double loaded or single loaded, sir? You'll be using a double loaded anchor?
No, I will be using single loaded only.
That makes life easier actually.
Yeah. So I am using triple loaded single row in cuff in all my patients. If I am doing single row and using single loaded anchors in bankers. Okay. Trocar sleeve, yeah. So this was the amount, this was the extent till what we have liberated the capsule and labral tissues. I will put my anchor just superior at around 5 or you can say 5:30 o'clock position
5:30. Yes.
to have the superior shift. So this is an curved drill guide. You can see a mark over the drill guide which suggests the direction of the curve. So it should, the curve should be facing like this, right? If I am not wrong.
Yeah.
The curved sleeves.
There's a mark here also.
Okay.
Can I-
Yep. Anchor, please. Drill
You are
fast.
placing the
Sorry.
anchor on the edge of the glenoid.
Last or left or right side?
No. It's catching in the sleeve. Remove it. So there is a mismatch between the drill sleeve and the. Give me the straight one.
Chirag, sir?
Yep.
Do you regularly use this curved sleeve or?
Yes, if it is available with the company, I regularly use. It is for the inferior most anchor only. The rest two anchors I use the straight sleeve. So I will incorporate this MGHL also in the proximal most anchor. So they are searching for the another sleeve. Meanwhile, you can ask any questions if you have.
Was there any glenoidal bone loss, sir? Yep.
See the glenoid bone loss. This is the bare spot over here. So you can see there is a subcritical bone loss. The decision of bone loss for me is entirely upon the CT scan base. It is not like measuring with the probe from posterior portal, measuring on the bone bare area anteriorly and posteriorly. Again, the trajectory or the angle of your marking mark probe would be different. So just check it. Yeah.
Because
Check? Okay.
from here, the
So it
anterior
is
margin.
only CT based, which I rely most for the bone loss. Yeah. Right. Green trocar. Green trocar. Green trocar.
Green top.
Lift it, please. So this is straight one or curved one?
No, same sir, 15 degrees down.
Okay. So drill.
placement of the anchor will be on the edge of the glenoid, sir?
What?
The placement of anchor
Yeah.
will be on the edge of the glenoid.
It is slightly more on the face of the glenoid for inferiormost anchor because the glenoid is very narrow in the inferiormost part. So inferiormost anchor, if you try to put on the edge of the glenoid or just on the face of the glenoid, it will come out from the opposite cortex. Okay. Switching stick, please. Switching stick. So now I am shifting my scope towards the posterior portal. No cannula is not required. Hold it, sister. Right one. First give me the trocar for this white cannula. Wait. Give me a grabber. Not retriever, I need a suture grasper. Yeah. So what I will do, I will grasp this capsulolabral tissue, lift it please a bit, and I will pull it upward. Hold it for me please. Suture passer, suture lasso. The right one. Hold, leave it. Give me suture retire first. Grasper please. Not this one. Fine. Let him search the thing which we are looking for. Put my mask on. Mask. Thank you. So maybe we are waiting for the suture passer, suture lasso. Yeah, that's it. Oh, you haven't loaded. This is no this looks straight. It is not 45-degree. Which other lasso do you have? So this one is left. The other one.
What lasso are you using, Chirag?
Sorry?
What is the lasso which you are using?
I'm
45
using
degrees?
45-degree left or right. So this is right shoulder for anterior both. This is not right. This is left. This is left. I need right. So for anterior labral, capsular labral repair, I use the same side lasso. This is right shoulder, so I use right side. When I will, if I use to take stitches into posterior part, I will use the opposite side. So this is the posterior inferior band of the glenohumeral ligament, posterior IGHL.
Yes. The grasper will not block the vision of your bite.
It will somehow, but still it can be managed.
Your bite will be slightly blind.
Which? It is right. It is just curved. It is not right or left. This one is also left. This one is also left. Well, we don't have the suture passer for the right shoulder. Okay, you give me the suture. Yeah. Load it. So we don't have the right sided suture passer. So I am using this suture passer. No. Load it again. Load it. Keep it small. Don't keep it too large. Keep it a little bit lower. I found. We have used this expressive mini, sorry, first pass mini for this bite. Normally I use the suture lasso kind of devices for the most inferior pass, but as it is not available, I have to use it. That's fine. Suture suture manipulator again. So I'm not going to use mattress stitch. I keep it simple and hold it for me, please. So you just check which one is the suture sliding through the tissue. So that one will be your post. So your knots will not lying on towards the glenoid side. Ati, please.
Are you putting the knot right now?
Yeah. I will finish the
You
job
don't
with the
want to
first
take another
anchor.
bite?
No. What?
Second bite. It's always better to take a second bite and then fix the first anchor.
I don't want to put the I don't like to do the mattress kind of stitch configuration over here because the one reason the tissue on mattress side the suture will be passing through only capsule. It will not passing through. It will not having any hold of the labrum, and capsule usually alone is weak. So that is one possible reason for me. So I like it to use as a simple stitch configuration. I don't use the mattress stitch configuration. So I will pass only one suture limb through the tissue, and I'm using this first locking sliding SMC knot, and then alternate 3 half hitches. So viewing from the posterior portal will solve the problem of overcrowding. I never use lateral row anchor in simple bankart procedure. I use lateral row only in bony bankart fixation, large bony bankart. So that will be a suture bridge kind of repair. Stoker and drill sleeve. Okay. Hammer, please. Yeah. Go on. Right lasso is already. Push it a bit, little bit.
This is 4:30, 4 o'clock position, sir.
Sorry?
What is the position of the anchor?
The
4 o'clock?
position is, yeah, it is almost 4 o'clock.
Okay. Roughly, what might be the gap of the first, the second
It is
anchor?
around 5 to 6 mm. Now Do we have the right-sided suture lasso? Okay. So we are preparing the suture lasso, which is just available right now, the right side one. So we have had only left-sided one. Forgot. So this one is the right-sided. Perfect. So the one trick is you can put your suture lasso here and rotate like this. So that amount of tissue you should take into your bite like this. Just palpate the glenoid bone and just climb it over gradually, and then you will come out. So
That is a good bite which you have taken.
did you check whether it is passing or not? No, just pull it. Hold it, sister. Wait. What? You can just give me ethylone. That will be reverse. It is not going in, it is wrapping around the wheel. What is it? Yeah. Hold it, sister. Here we have the proline. Not going. So we have some issue with the suture passer.
The lasso is not good.
Yeah, suture lasso is not working. कौन सी कंपनी का है? Which company of Electronics? Keep a little bit out.
What we have to first on
Yep. Hold it. Rebel.
No, grasp.
Lift a bit, please. The grasp for other one will be required next time. Mr. Hold it, please. Not like this. Take this. Look it in. Hold the cannula, please. Pull it, pull it, pull it. Okay. Not pusher, please. Artery, please. So that is our first knot going in. You can see nice bumper.
Yes, yes. It's a good bump.
Okay, good. So 2 anchors, one more anchor to go. So that will be almost around 3 o'clock position, my third anchor. Will be somewhere here. Fine. Oh. Yeah. Okay. So everyone in hole is sleeping or they are awake in post-lunch surgery? Looks like sleeping everyone there.
No, nobody's sleeping. Nobody's sleeping.
Nobody's sleeping.
Watching.
There is no voice from that your side. Lasso, please. So this is the part of MGHL, and while taking the most superior bite, I'm a bit careful that I do not take bite through the subscap. I don't want to take my bite through the subscap. और दूसरा वाला क्रॉस कर दो, रेड वाला. Pull it. Wait, wait. Okay. Not pusher, please. Butter. So our anterior job is done. Now I will switch my scope to the anterosuperior portal. So now you can see before tying the remplissage, the head is very well centralized. This is our anterior labral tissue repair. So it looks okay. I don't want to plicate the posterior capsule now. I'm just using the two anchors to stabilize it posteriorly. Come on this side.
You want to do a posterior repair also?
Which one is inferior? We don't know.
Second one.
This one is first one. No? So we will tie the remplissage sutures from inferior to superior. So this one was the inferior, okay.
Push up.
Not pusher, please.
Artery.
So I am having reading glasses now, what I think, but I am just reluctant to wear any glasses. So usually my assistant does the job of not time. But I could not bring him here. These people are quite efficient and they are very helpful. Patel. Chodo. Thank you. Patel, please. Thank you. So you can see the entire Hill-Sachs defect is completely filled almost. It was a very huge Hill-Sachs. So this is after completion of the Hill-Sachs defect remplissage. You see, it is very well filled, and this is the anterior tissue which is filled, and you can still take a posterior bite if you wish to. So for the demo purpose, I will show you how you can do the posterior plication. Give me the right-sided suture passer, sorry, left-sided suture passer, this one. Yeah, it is loaded. Load it with the chia wire or something like that. Do we have time?
Yes, sir. Probably 5 minutes. It's fine.
Okay. It will take only 2 minutes.
Yes, sure.
The left-sided, so for the posterior work, I will use the left-sided suture passer. Normally, I do it before tying the Ramplisa sutures. So I do not use cannula here posteriorly, working here, because what happens, the cannula will restrict the mobility of instruments for me in the posterior portal area. Lift a bit, little bit. Just tucking up the inferior capsule. Grabber, please. Need a grabber. I need a free number 2 wire, or you can use from that thread longer if available. No. Number 2 fiber wire, please.
Open 7004.
Okay. Give me suture manipulator. So after tying the posterior amplissage, it is a little bit difficult because there is a shifting of capsule and portals. So we are just struggling a bit for retrieving the sutures. Hold it, the camera. Lift a bit, please. So this is the postero-inferior application of the capsule. You can see the tummy tuck over here. So there is a loose synovial fold which is lying anteriorly, so we are not able to visualize it. The application. You can see here, that is our application suture. Anything else you want to know?
No, everybody is happy with the procedure.
Sorry?
All of us are very happy with the procedure.
Very happy with the.
Hello?
Yeah, I am happy
can
with
you
the
hear us?
procedure. It is quite stable.
No,
I'm
here,
happy
here
with
all
the
of us are also
repair.
happy with the procedure.
Yes, sir.
What?
That was a wonderful demonstration. Everyone is happy with the final outcome. It's a wonderful labral repair remplissage and also the posterior capsular application.
Okay, thank you.
And special thanks to Chirag sir, because I know you have traveled from Ahmedabad with fever and you have been in the hall through the sessions and you have done a live surgery
Yeah, I'm
with, under
taking
the
the
support of
paracetamol,
paracetamol.
guys. I took 2 paracetamol in the morning today also.
Yes, sir. Thank you so much, sir.
Thank you for the invitation and thank you entire the hospital staff, specifically anesthesia team,
Yes.
for helping me out to carry this
It
live
was-
surgery demonstration, and thank you the Vizag arthroscopy team. Thank
Yes,
you.
sir. Thank you, sir. Thank you. Sir, live surgery, Vijay Kumar and team, anybody can hear us? Vijay Kumar and team?
एक फोटो ले लो हमारा सबका.
Yes. So that is our anesthesia team. Yeah, please stay there, focus. So, Anuradha madam, Kranti, and those are our, yeah, Naveen sir, Naveen sir, can you come forward? Yes.
Sir, Srinivas is there, sir, for
Yeah, so
audio.
all the dark blue. So the front madam is the HOD Anuradha madam. So behind Naveen sir and Kranti. So there's an extraordinary anesthesia team. Madam, sir, everybody, thank you so much. The anesthesia has been great throughout the surgery. And it was a big round of applause to the anesthesia team for Care Hospitals. On a Sunday, madam has organized really well. So there's a dedicated 12 people per team per each OT. And only madam and the team can pull off such a thing despite having an emergency craniotomy. So we are forever indebted to Care Anesthesia team. And that is our entire crew for this OT. Sir with and Dr. Surya, the one standing behind Chirag sir. And Vaibhav is there to the corner. And that is our entire nursing staff there. So we thank you everybody. Thank you so much. And all the OT technicians and everyone. Yeah, thank you so much.
Yeah, sure.
Yeah, now we have a case presentation by one of the delegate. So it's a interesting case, a short and sweet case by Dr. Ramraju. So Ramraj is a consultant at KIMS Hospital, Visakhapatnam.
Hello. Hello.
Pointer on the is point.
So the workstations are being set up outside and the simulator. So after the case presentation, we'll have a small valedictory and we'll proceed to the workstations and simulator.
Good evening, everyone. This is a small case presentation. This patient is a 39-year-old male. He's a clerk and he had come to me after a month of his right shoulder pain. Mainly if I ask him where the pain is, he says it's the back of his shoulder. So he has this constant pain and I probed a little bit. He said like, I never had any injury. He could not recollect any injury at all. And he has this pain unrelated to any activity. No overhead activities are bringing him any sort of pain. And so after a month of this suffering, he went to an orthopedician who gave him a steroid. But pain has subsided. And after 1 month, it has again recurred. So that is when he showed up to me. When I examined him, he had no swelling, no wasting, and there is no joint line tenderness or any other sort of tender points. So his movements, the forward flexion, he could do comfortably. Only thing is that the terminal range of motion was little painful. Abduction, he could do both in pronation and supination. His capstan maneuver was negative. And he has this passive external rotation. He could do entire 45-degree without pain. And internal rotation is slightly limited. He is going his hand up to T9. So when we check the rotator cuff, his supraspinatus was 5/5, 5, subscapularis was 5, but infra was only 3. So other impingement tests like Neer and Hawkins-Kennedy both were negative, and O'Brien was positive, and no signs of any AC joint involvement. And here is a clinical video. You can see his left pathology is on the right side. He could do his forward flexion well, but you can see the patient struggling there with a terminal forward flexion, and his abduction was good and without any pain throughout the range of motion. So this is his passive external rotation of the normal side, which is up to 45-degree, and similar range of motion is there on the even the right side. And you can see when he turns to the back, you can see he's kind of fatty patient. So there is, I could not appreciate any swelling or, atrophy of muscles. Internal rotation was T9, and his both deltoid and supraspinatus both were 5/5. And you can see this Gerber's lift off also, he could give a 5/5. Now this is the infraspinatus external rotation testing, where you can see on the right side I could easily check his power, which is very less compared to the unaffected side. This is again Hornblower, where equal power of teres minor and In the horn blower test is negative, you can say. So I had a few clinical diagnoses in mind, and on objective testing, I could only think of an infraspinatus tear. In fact, that's the first thing that came up to my mind. But I haven't seen a single patient who has presented to me with the isolated infraspinatus tear. The second thought was he could have some neuropathy, which could be suprascapular. And here the O'Brien test and all these things also suggested kind of a slap tear. And because of the posterior shoulder pain, I was thinking about internal impingement too. But there are no signs of external impingement. So this is his MR, axial cuts. If you can see in that section, you can see the anterior labrum is very good. That is the anterior superior labrum. And if you come down, this part has lifted off. That's a posterior superior labral tear. And one more thing very highlighted here is the hyperintense signal you can see here, right? All 4 or 5 sections. So if I can tell you, this is the glenoid and this is the spine of the scapula. So this is a this is a cyst between the spinal glenoid and the scapular spine. You may have to take a new portal also posteriorly to get to there. Luckily, I got my first portal itself was giving good angle, so I did not go for a new portal. So you can debride the edge of the labrum to create biology, as I shown in the previous videos. We do the similar thing, but we do in a mirror image, like at the back of the shoulder. So once you're done, elevated and created good biology, just go in there, put some anchors, all suture anchors, take out the bites with a bird beak, and tie up those sutures, and number of, depending on the size of the, size of the tear, you can put as many number of anchors as you want to. This is just like how you do a labral repair, but little bit of angle will be a little difficult here. You can see you can use any of the instrumentation device like an acupass or a bird beak. So you can see this again, the lifted off labrum getting stitched. So that so this is, how do I play this? Yeah. So this is the, as I had shown this video before, this is a power of the infraspinatus before surgery. You can see he is not able to completely resist my hand, but once you come to the post-op, this affected side is the right side. So what you are seeing, this is the right hand. So he developed equal power compared to like as other unaffected side. So again, we got an MRI after surgery, 6 months after surgery. So here you can see the cyst, right, all throughout. If you go there, there is complete loss of that hyperintense signal. I can say that cyst has completely resolved. Similar picture you can see in the pre-op images. You can see the cyst here and some inflammation in, and this is inflammation in infraspinatus muscle. But if you see here, the infraspinatus, the cyst has completely, some little part is left. I think it in time it will also resolve, and it's a good bulk of infraspinatus there, which can be seen in the clinical power testing. Similarly, sagittal images, the spinoglenoid cyst here, and see that we have put some anchors which can be seen, but the cyst has not progressed or even has almost completely disappeared. So my take home message is, these cases do come, it's not so rare. So if you, this is a typical case scenario where you will find isolated infraspinatus weakness, which is not seen in other scenarios, and it's very unlikely a degenerative tear or a traumatic tear without a supraspinatus will have only infraspinatus involvement. I don't think any of the delegates have seen traumatic tears like that, infraspinatus. So always keep in mind that this is a possibility. So when you have isolated infraspinatus, always keep suprascapular neuropathy in mind, which could be due to a spinoglenoid cyst. So here main part of the thing is, as like any other laboratories, you have to create a good biology. And see, as I said, there are many treatment options, but the arthroscopic gives the best result, because this cyst will have a mouth which feeds into the stomach. So you have to shut the mouth to stop feeding. So arthroscopy is definitely advocated for this kind of procedures. Thank you very much for the opportunity, SRS team. I think Rajshekhar sir has come up with a question. I know he always asks me a question, so I'm very happy.
Good job, Ramraju. That's a wonderful presentation. Really decompressing the spinoglenoid cyst is a complicated procedure. Well done.
Sir, your English is so good, I can't understand.
Yeah.
Can you little bit slow down?
No, it was very good. It was very good, Ramraju.
Thank you, sir.
Yeah.
Thank you so much.
My question is, was your decompression intentional or it just happened?
I haven't done decompression, sir. I just did a labral repair.
No, you said that the fluid was peeping out from the labral tear.
That was just giving a push, it seeps out.
Yeah, it was not intentional.
Yes, sir.
Yeah. Will there be any indication for you where you decompress it before suturing? I mean, are there any pressure effects on the suprascapular nerve if you find clinically, or is there any volume of the cyst if you feel where you need to decompress it before fixation, or there are no such cases?
Sir, for a simple spinoglenoid cyst, which is a focal one like this, we need not have to decompress the cyst. But if there is an extensile cyst which goes into the suprascapular notch and compresses the suprascapular nerve before it supplies the supraspinatus, then that is the time we may have to decompress the cyst and decompress the nerve.
Oh, great job, Ramraj.
Thank you so much, sir.
Yeah, one more question. Do you feel like before knotting your labrum, do you feel that it's better to do in a dry scope the last knots? Because still, being a mucoid degeneration, the pressure of fluid still have a chance, as you said, there's an open mouth for a stomach.
Dry scopy before putting my labral stitches.
Yes. Because there's always a chance.
You mean post after even after put bites, fluid will ooze out and will hamper healing. That's what you mean?
No, no, no. I'm just I'm
Recurrence.
just, yeah,
Sir, as soon as we so if we achieve a good labral repair, create a biology, and if your labrum is sticking very well after your repair, I don't think it will recur. That's what my experience. Maybe I don't know.
Yeah, I'm just asking, is it a good idea to be a dry scope before stitching? After that, you can do.
You mean suck out all the cyst material?
It's not about sucking out all the cyst
Why
material.
are we doing a dry scopy here? Like what?
Not right now. Before you're just approximating your labrum to the glenoid.
Mm-hmm.
Why don't you give a dry scope before giving your final knots?
No, sir, that's what I'm asking you. What advantage do you if we use
pressure, even your saline pressure is equally have a chance to seep into it, right?
Okay, okay.
You did a scopy under saline, right?
Oh yeah, okay.
The same pressure.
Maybe it will help, sir. I think I will try it next time.
Yeah.
I have no experience with that.
That's
So,
okay, fine. Yeah.
Thank you.
Good guess.
Thank you, Ramaraju. That was a very classical case of spinal glenoid cyst. Very well managed with a very good outcome. Thank you so much. So I would like to invite Dr. Raghavendra to the stage. Ashish sir, okay. And also Dr. Ashish sir, to give the mementos for the workshop faculty, workshop and simulator faculty. I call upon the faculty, Dr. V.V. Rajshekar. Dr. Gangaraj garu. Dr. Ramsai, Dr. Karthik Paidi, Dr. Shivaram Raju, Dr. Chiranjeevi, Dr. Sandeep, Thank you, sir. Thank you, everyone. And just 2 minutes of vote of thanks, and then we can proceed to the workshop stations and the simulator stations. Rajesh.
Yeah. Thank you, everyone, for coming. I sincerely thank Ias core team, Dr. Ragumagam sir, who is the president, and Dr. Ayyappan Nair and Dr. Chirag for their wonderful demonstration of live surgeries, and Dr. Ramakant, Dr. Virendra, Dr. Raghavendra for sharing their expertise, and our organizing chairman, Dr. Shivanand Garu, Dr. Loknath sir, Dr. M.C.H. Naidu sir, for extending their support from the Department of Orthopedics, Andhra Medical College, and Arthroscopy Society, Association of Andhra Pradesh, office bearers, Dr. Aslam sir, Dr. Sridhar sir, Dr. Praveen sir, Dr. Ashish sir, who have been the forerunners for arthroscopy in Visakhapatnam, and for their guidance in organizing this event and making it a big success. And our NOA Secretary, Dr. B.V.N. Verma sir, our care hospital FCO, Mr. Mayuk, Dr. Sodan and Dr. Keetana, all our medical college HODs for encouraging their postgraduates for this session. Our Seronics team, the central team, which consists of Sudeep, Ritesh, Chitra, Suhas, and our local team, Amar and Shekhar, for their continuous support and ground level support. What they have done is fantastic. And our Bhuvante Surgicals, Rupesh, Ramu, and team, and Fantastic audio visuals by Mr. Vijay Kumar. 4 points management. Our support staff, Ramesh, Ashok, and entire SRS team. Last but not the least, thank you audience, thank you delegates for coming to this event and making it a great success. Thank you one and all.
Okay, we have the workshop stations, 2 implant and instrument workshop stations outside and 1 simulator station. So we can just, yeah. And the delegate kit and the registration certificates are available at the counter outside. Cyronix, some Cyronix, Shekhar garu. Hey, faculty, go. ఇది రంగరాజ్ సార్ది బాలది ఓకే రంగరాజ్ సార్ ఒకరిది మురళీకృష్ణ సార్ ఒకరిది ఇది ఇద్దరివి మనం చేయించి
check
రూపేష్ ఇది ఇచ్చే రమేష్ ఇది ఇచ్చే
చెప్పాను